Welcome everyone. This evening we'll be covering Chapter 20, Gastrointestinal and Urologic Emergencies. So gear up, let's get ready to learn. Today in our objectives, we're going to identify causes of acute abdominal pain in female patients. We're going to recognize symptoms and management of pelvic inflammatory disease. We're going to understand ectopic pregnancy risk and shock progression. We're going to identify UTI symptoms and complications in the urinary tract. We're going to recognize signs and symptoms of chronic kidney disease, and we're going to understand causes and signs of acute kidney injury. We're also going to identify symptoms and risk of benign prostate hypertrophy. We're going to recognize presentations of testicular masses, benign and malignant. We're going to understand causes and management of priapism. We're going to recognize signs and risk of end-stage renal disease. All right. So let's get started with a topic you'll encounter frequently in the field, abdominal pains, right? So this is a common complaint, but it can be one of the most difficult to diagnose, even for a physician. The causes of abdominal pain can range from minor issues like indigestion to real life-threatening conditions like a ruptured aneurysm or severe infection. So as an EMT, it's going to be crucial to remember that you're not expected to pinpoint the exact cause of the pain. Your role is to recognize potential life-threatening issues and act swiftly. Key red flags include signs of shock, significant changes in mental status, or abdominal distension. These signs should immediately raise your suspicion of a critical problem, right? So now, think about the patient in front of you. Pain, especially severe abdominal pain, is very distressing. Your ability to provide not only rapid assessment, but also emotional support will make a huge difference in their care, right? So a patient in pain is likely anxious, scared, or disoriented. Your calm demeanor and your clear communication can help alleviate some of their anxiety, just some of it, okay? So at this point, I want you to think through a scenario. What if your patient is experiencing an abdominal pain with a blood pressure of 88/60 millimeters of mercury and a heart rate of 130 beats per minute? These findings suggest hyperperfusion, right? Hypoperfusion, right? Hypo meaning lower. Possibly, this could be due to an internal bleeding or another severe cause, right? How would you prioritize your assessment and treat in this situation, okay? Remember that at your level as an EMT, recognizing that situation and initiating that rapid transport is going to be very critical for you. All right, so now, anatomy and physiology. The abdominal cavity contains a variety of solid and hollow organs that are part of the gastrointestinal, genital, and the urinary systems. Understanding this anatomy is key when assessing a patient with abdominal pain, as it's going to help you consider a patient that may have underlying issues, right? So let's start with the solid organs. These are going to include the liver, the spleen, the pancreas, kidneys, and in women, we're going to have the ovaries. Solid organs are going to be dense, and when they're injured, they have the potential to cause significant internal bleeding and lead to shock, okay? So, for example, if the spleen is ruptured in a traumatic injury, the patient may experience rapid blood loss into the abdominal cavity, which can be life-threatening, as you know. So now, hollow organs, which we'll discuss later, they present different challenges. But it is crucial to note that the cause of abdominal pain can be difficult to pinpoint. Every physician will assess the imaging and advanced diagnostics that can struggle to identify the exact source. All right. So as an EMT, your main focus should be on identifying the signs of shock or that internal bleeding that can be caused from any type of injury that's in a solid organ, right? So symptoms such as low blood pressure, increased heart rate, and a pale, cool skin should alert you to that possibility of shock. Immediate action, such as initiating rapid transport, is going to be very important for you in that EMT role, right? Or a EMT role. So if you encounter a patient who suffered blunt trauma to the abdomen and has signs of shock, what would be your priority? Would you focus on stabilizing them on the scene, or are you going to expedite your transport to definitive care? So think about that for a little bit as we go. The gastrointestinal system, or gastrointestinal as in GI, also this is referred to as the digestive tract. It plays a crucial role in the body by absorbing the products of digestion to provide fuel for cells, okay? So understanding the structure and the function of the GI system helps you make sense of many abdominal complaints that you'll encounter out in the field. So the GI system starts at the mouth, right, where food is broken down by saliva and chewing, that mastication, right? So from there, it passes through the pharynx and esophagus. And then it reaches into the stomach, where further digestion is going to occur. So the small intestines then absorb the nutrients, while the large intestines are going to handle waste. So this system also includes accessory organs like the liver, which is going to process nutrients. It detoxifies substances. The gallbladder, which is going to store bile. And the pancreas, which regulates blood sugar and aids in digestion. So the process finishes in the rectum and anus, where waste is then expelled out, right? So when a patient presents with abdominal pain, the issue could stem from any part of that system, making it essential to consider each component in your assessment. While you don't need to diagnose the specific problem, recognizing potential complications, such as when we're talking about like a blockage, inflammation, or bleeding, this is going to help. It's going to help you focus on immediate care for that patient. All right, so think of this. If a patient complains of diffuse abdominal pain and you notice jaundice, that yellowing of the skin, right? What might you suspect as the underlying problem? What immediate steps would you take to stabilize the patient? The entire digestion process, from the moment food enters the mouth until waste is expelled, takes anywhere from 8 to 72 hours. It starts with the salivary glands secreting saliva to lubricate the food, making it easier to swallow, right? Once swallowed, the food travels down the esophagus, which moves it towards the stomach through this rhythmic contractions that's known as peristalsis. Peristalsis, that rhythmic contraction. So the esophagus is separated from the stomach by the cardiac sphincter. This is a valve that prevents food and stomach acid from backing up into the esophagus. So when this valve fails, it can cause discomfort, or it can cause conditions like acid reflux. Now, intertwined with the esophagus are veins that drain into a complex system of vessels, which eventually form the portal vein. So the portal vein, it plays a critical role in transporting venous blood from the gastrointestinal tract to the liver. Here, the liver processes the nutrients absorbed during digestion. So this is going to be a very vital step in ensuring that nutrients are available for use by the body. However, if blood flow through the liver is obstructed, or if it's slowed, it can cause a dangerous backup of blood in the GI system itself. So even low amounts of pressure in those veins, it can lead to vessel leakage or even rupture, which may result in significant internal bleeding. No good, right? So let's think about this on the clinical side. If you encounter a patient with a history of liver disease who shows signs of abdominal pain and GI bleeding, what complications might you expect from that? How would this affect your treatment priorities, and what actions should you take to ensure rapid transport? All right, the stomach plays a crucial role in digestion by secreting hydrochloric acid to help break down food. So the acid allows the stomach to chemically digest the food that we eat, making it easier for nutrients to be absorbed further down in the digestive tract, right? So in addition to its role in breaking down food, the stomach also absorbs some substances directly, such as like your water, your alcohol, caffeine, and certain medications. So one important feature of the stomach is its ability to stretch far beyond its normal size to accommodate for large meals, right? So this elasticity Also, it's going to allow it to hold food for the time it takes to process before slowly releasing it into the small intestine for further digestion and nutrient absorption. So it's important to remember that while the stomach is highly resilient, certain factors like overuse of alcohol, medications, or infections, it can cause damage to the lining. And this is going to lead to pain or more serious conditions like ulcers or gastrointestinal bleeding. So as an EMT, you're going to recognize when abdominal pain could indicate a serious stomach issue, such as when we're talking about that bleeding. That's going to be very critical. So think about this. If a patient presents with severe abdominal pain, nausea, and a history of alcohol abuse, what are some of the potential stomach-related complications that you should consider? Could this patient be at risk for bleeding, a bleeding ulcer, or even a perforation? How would this affect your decision to prioritize that transport and initiate care? What are you going to do? The duodenum. As the first part of the small intestine, this is where the next phase of digestion begins after food leaves the stomach. Remember how we discussed the stomach's role in breaking down food with hydrochloric acid? Well, here in the duodenum, the small intestine starts to absorb nutrients that are going to be essential for your body. So the stomach releases small amounts of food at a time, just small amounts at a time. All right, and this is going to help the duodenum manage the digestion process more effectively. So what makes the duodenum particularly important is that it's also the point where the pancreas, the liver, and the gallbladder contribute to digestion. The pancreas secretes enzymes into the duodenum that break down fats, proteins, and carbohydrates. Essentially, this is going to turn food into a form that the body can actually use. So one key enzyme, amylase, it's amylase, all right? So it breaks starches down into sugars, all right? So the pancreas also produces bicarbonate, which is going to neutralize stomach acids and insulin. So this is going to help regulate the blood glucose levels in your body. So this is going to be important to remember, especially when we encounter those patients with a history of diabetes or pancreatic issues. A disruption in any of those functions, whether it's enzyme production, neutralizing acid, or regulating blood sugar, can lead to these serious complications. All right, so think about this then. So if a diabetic patient presents with severe abdominal pain, the first critical decision is determining whether the pain could be related to a problem with digestion or blood sugar regulation. So you as an EMT, your first steps should include assessing the patient's blood glucose level to rule out any hypo or hyperglycemia. If the blood sugar is abnormal, your immediate treatment should pretty much focus on stabilizing those levels, okay? So you may need to administer glucose for hypoglycemia, or you need to prepare for rapid transport for hyperglycemia, right? Especially if they show signs of like your diabetic ketoacidosis or that DKA. So you should also assess for signs of pancreatitis, such as pain radiating to the back, nausea, vomiting. That rapid transport is going to be very important for both of those conditions. So after stabilization, prioritize patient transport to that advanced care, right? All right. The liver is a critical organ in the digestive process and has several essential functions that go beyond just digestion. So first, it assists in digestion by secreting bile, which is going to help break down fats in the small intestine. But the liver also acts as a filter. It removes toxic substances that are produced during digestion and keeping harmful materials from entering the bloodstream itself. So beyond its role in digestion, the liver plays a key part in glucose regulation. So it creates and it stores glucose, ensuring that the body has a quick energy source whenever it's needed. In addition, the liver produces proteins necessary for blood clotting, and it helps support immune function. This makes it very essential for the body's defense and the recovery processes. A liver injury or a disease such as like when we're talking about cirrhosis or hepatitis can disrupt those vital functions, leading to complications like bleeding, infection, or other issues with glucose regulation. All right, so something to think about. If you encounter a patient with jaundice, which is that yellowing of the skin and the eyes, and they have abdominal pain, the critical decision is determining if the liver is impaired at that point, right? So your immediate steps should be to include assessing for signs of hypoglycemia, as the liver's ability to store and release glucose may be compromised. So you're going to monitor the patient's vital signs closely, right? Especially if we're going to be looking for those indications of shock, and we're going to prepare for that rapid transport. In cases of liver dysfunction, bleeding complications are also possible. So you should also assess for signs of internal bleeding and manage that accordingly also. The small intestine is where most of the body's nutrient absorption takes place. It produces enzymes that break down chyme. So chyme is this partially digested food from the stomach. That's what that is. So that breakdown of chyme, it's going to do this into substances that can then be absorbed by the capillary linings in the intestines. So once nutrients are absorbed, they enter the bloodstream and are transported to the liver, where further metabolism of fats and proteins are going to occur. So blood then leaves the liver and it continues its journey into the subclavian vessels. And there they're going to deliver nutrients throughout the rest of the body. So water-soluble vitamins are going to be absorbed there. So it makes them ready to be used by the cells themselves. So the small intestine is divided into three parts. You have the jejunum, which makes up the large portion of the small intestine's surface area and does most of the absorption. The ileum is going to be the final part of the small intestine, and it absorbs the remaining nutrients that weren't absorbed earlier in the digestive process. It also reabsorbs bile acids, sending them back to the liver for future use, recycling, right? And it also absorbs vitamin B12, which is going to be essential for making nerve cells and red blood cells. All right, so just a little thought. If a patient presents with severe malnutrition or unexplained fatigue, the critical decision here is going to be to recognize that absorption issues in the small intestine could actually be a factor in this. So what you're going to do is you're going to assess this patient's history, including any gastrointestinal diseases or surgeries that could affect nutrient absorption. While stabilizing the patient, you're going to ensure that they are prepared for transport and that advanced care, as if you have prolonged malabsorption, it can lead to a critical deficiency like anemia or neurological issues due to the lack of vitamin B12. So the large intestine, or colon, is where substances that haven't been broken down or used as nutrients enter as waste products, also known as feces. So the primary role of the large intestine is to reabsorb water from those waste products. And this is going to help to solidify the digestive material and form stool. All right, so this process is critical in maintaining fluid balance in the body. So the colon's osmotic function, it's going to aid in this process by drawing water out of the waste material, creating a more solid stool. In addition to water reabsorption, the colon is also the site of that bacterial digestion. So bacteria found naturally in the colon, it helps break down any remaining nutrients in the chyme. And as a byproduct of this bacterial digestion, gas is produced. So once the waste reaches the final portion of the colon, it passes into the rectum. So the colon ends at the anus, okay? So this anus it's a sphincter that controls the release of feces from the body. We should all know this by now. So let's think of this type of patient. So if you encounter a patient with severe dehydration or signs of an electrolyte imbalance, the critical decision here is to consider whether dysfunction in the large intestine's water reabsorption might be a contributing factor here. So assessing the patient's hydration status, monitoring the electrolyte levels, and then recognizing symptoms like diarrhea or prolonged GI issues can help you make an even better informed decision on this. Also, administering fluids and then preparing for transport to that advanced care is going to be a huge part in your treatment process. All right, so although the spleen is located in the abdomen, it plays no direct role in the digestive system. Instead, the spleen is part of the lymphatic system, and it serves critical functions related to red blood cells and the immune system. Its main role is to filter blood and removing old or damaged red blood cells from circulation. In addition, the spleen aids in the production and development of new red blood cells there. And this is going to ensure that the body remains, or that it maintains a healthy supply. So the spleen also acts as a blood reservoir. So what it does is it's going to store extra blood that can be released into the circulatory system during times of significant blood loss or shock. On the immune side, the spleen produces antibodies that help to fight off diseases and infections, making it a crucial component in the body's defense system. So while the spleen is important, injuries to it, particularly from blunt force trauma, can lead to serious internal bleeding then. So rupture of the spleen is a life-threatening emergency due to the large blood supply that it contains. All right, so let's think about when we're talking about this with a patient. So if you encounter a patient with a left upper quadrant pain following trauma, especially with signs of shock such as hypotension and tachycardia, the critical decision that you're going to have to make is that you need to suspect splenic injury. So as an AEMT, your priority should be to include monitoring for signs of internal bleeding, initiating that fluid resuscitation, and then ensuring rapid transport. Splenic injuries can quickly lead to hemorrhagic shock, so quick recognition is going to be very important for you there. All right, the abdominal space not only holds digestive and lymphatic organs, but it also contains parts of the reproductive system. The male and female reproductive systems play key roles in human reproduction, and while they don't directly contribute to digestion, they can be involved in abdominal pain or trauma cases. All right, so in the male reproductive system, the testicles produce sperm, which are stored in the epididymis and travel through the vas deferentia. All right, so the seminal vesicles and the prostate gland add fluid to the sperm, which creates semen. So the semen, which is then expelled through the penis during ejaculation. All right, so injuries or infections in this system can cause abdominal and pelvic pain also. And conditions like testicular torsion can require rapid intervention in a lot of cases. All right, also in the female reproductive system, it includes the ovaries, which produce eggs, and the fallopian tubes, which transport the eggs to the uterus. So the uterus, where fetal development occurs, connects to the cervix and the vagina. So pain in the female reproductive organs could be due to conditions like ovarian cyst, ectopic pregnancy, or infections. All right, so think of this patient. If a female patient presents with lower abdominal pain, consider the possibility of a reproductive issue such as possibly an ectopic pregnancy, or it can even be an ovarian cyst. So the critical decision is to assess for, or ovarian torsion even, but the critical decision is to assess for signs of internal bleeding or shock, especially if the case is acute, all right, and if they have that severe pain with it. So what you should do is prioritize that rapid transport while you're monitoring signs for hypervolemic shock, as those conditions can become quickly life-threatening, right, if they don't have any surgical interventions pretty soon. All right, so the urinary system is going to be responsible for filtering waste products from the blood and removing them from the body in the form of urine. It's going to consist of several key organs, each playing a vital role in its filtration and the elimination process. So the kidneys filter the blood, removing waste and these excess substances, which are then going to be converted into urine. So this urine is transported to the urinary bladder via the ureters. The bladder stores the urine until it is full and ready to be excreted. So when the bladder contracts, urine exits the body through the urethra. So understanding the function of the urinary system is important because if you have issues such as kidney stones, infections, or trauma to the urinary tract, it can cause significant pain and other complications with this. For instance, blockages in the ureters or the urethra can lead to severe abdominal or flank pain. So, as well as it can give you difficulty urinating. All right, so think of this type of patient. So if a patient presents with flank pain and blood in the urine called hematuria, okay? Hema, blood, or hemat, blood, urea, urine. Easy, right? So, and also they have this difficulty urinating. A critical decision is going to be to consider whether there could be a blockage or is it an infection in the urinary system. So you should assess for those signs of shock, especially if the patient is in severe pain and has signs of dehydration. Initiating pain management and fluid resuscitation along with rapid transport would be the key thing that's going to win the day in this instance. All right, so the urinary system has two primary functions that are essential to maintaining the body's balance and overall health. So first, it regulates the levels of electrolytes, water, and acids in the blood. So this balance is vital for normal cellular function and maintaining blood pressure. Second, it removes metabolic waste, drug metabolites, and excess fluids from the bloodstream, excreting them in urine, right? We talked about it last slide. So the kidneys are constantly performing these critical functions, filtering around 200 liters of blood every day. So this filtration it's going to ensure that waste products and excess substances are removed while important nutrients and electrolytes are reabsorbed into the bloodstream as needed. Without the kidneys' continuous filtering process, harmful substances could accumulate, leading to serious health issues in these patients. So kidney function is especially important in emergency situations as conditions like dehydration, electrolyte imbalances, or toxic substance exposure can quickly overwhelm the body's ability to maintain equilibrium. So think about these patients. So if a patient presents with altered mental status, muscle cramps, or irregular heart rhythms, the critical decision is to consider electrolyte imbalance or kidney dysfunction. As in your position, you're going to assess for signs of dehydration or abnormal fluid retention. You're going to monitor vital signs very closely. You're going to initiate fluid resuscitation and prepare for that rapid transport. And you see the trend that I'm trying to get here. For a lot of these type of injuries, this is probably what you're going to do, right? I think you got it. All right, the kidneys play a vital role in maintaining the body's homeostasis. In addition to filtering the blood, and they produce hormones that help generate new red blood cells, and they assist the liver in converting glycogen into glucose. The nephrons located in the cortex of the kidney are the structural and functional units responsible for forming urine. So a key role of the kidneys is balancing electrolytes like calcium, magnesium, and phosphate. So they achieve this by eliminating metabolic waste products such as urea from the blood. If the kidneys fail, the body cannot excrete this urea. And this is going to lead to a dangerous condition called uremia. All right? So this is where waste products build up in the blood, and that's not good. So once urine is formed, it enters the collecting ducts it enters the collecting ducts and it flows through the minor and the major, the calces, all right, or calyces. And then it's going to reach the renal pelvis. So from there, urine travels down the ureters, one for each kidney. All right, we got one ureter for each kidney. And it's going to be stored in the urinary bladder until it's expelled through the urethra. So the brain controls the urge to void by keeping the external urinary sphincter contracted until conditions are going to be suitable for that urination process. So in these patients, in a patient with suspected kidney failure presenting with confusion, fluid retention, or signs of uremia, the critical decision is going to be to recognize that severity of their condition. What you should do is focus on assessing the patient's vital signs, looking for signs of shock or electrolyte imbalance. Rapid transport, advanced care is going to be to manage that kidney failure. All right, so this is going to be where dialysis may be required to filter waste products from the blood if this starts to happen. All right, acute abdomen, it refers to the sudden onset. So peritoneum is a thin membrane that lines the entire abdominal cavity. So when the peritoneum becomes irritated, it can lead to a condition called peritonitis. All right, so this is going to be a serious medical emergency, peritonitis is. So peritonitis can result from various causes. This can, including things like infections, penetrating abdominal wounds, blunt trauma that damages internal organs, or even diseases that are going to affect the abdominal region. So the most significant symptoms of peritonitis is severe, persistent abdominal pain. So clinically, you will often you're going to observe this abdominal tenderness and distension in these patients. Okay, so these signs you got to be alert for to the possibility of a peritoneal irritation, which requires immediate attention and probably transportation. So when faced with a patient presenting with sudden severe abdominal pain and signs of peritonitis, your critical decision is to find out what's going on with any type of underlying trauma, infection, or organ damage. So again, you're going to assess those vital signs for shock, you're going to manage their pain, and you're going to prepare for transport. So ensure that you monitor the patient, or if there's any changes in mental status, if you get changes in mental status or worsening of those symptoms, those can be something more severe. So those IV fluids, all of that good stuff, fast travel to the hospital are going to be what wins the day in this situation. All right, the peritoneum consists of two layers: the parietal peritoneum and the visceral peritoneum. So each of them are going to play different roles in the body's response to abdominal issues. The parietal peritoneum lines the walls of the abdominal cavity and is going to be supplied by the same nerves from the spinal cord that supplies sensations to the skin over the abdomen. So this means that the parietal peritoneum can perceive sensations such as pain, touch, pressure, heat, and cold, and it can easily localize the exact point of irritation. And this is going to make it very responsive to injury or inflammation as well. So on the other hand, the visceral peritoneum covers the surface of each organ within the abdominal cavity and is going to be supplied by the autonomic nervous system, all right, ANS, right? So unlike the parietal layer, the visceral peritoneum doesn't localize pain as precisely. Instead, it responds to distension, It responds to distension or contraction of the hollow organs, which activate stretch receptors. So this type of pain is often felt as colic, which is severe cramping and intermittent in nature, okay? So if a patient presents with diffuse cramping abdominal pain, this colic, it's essential to differentiate whether the pain is coming from the visceral or the parietal peritoneum. So it's going to be a critical decision in this factor to assess whether the pain could be related to distension of the hollow organs, such as like with a bowel obstruction, or if it's more localized pain, it might indicate something with the like appendicitis. So in your job, your approach should be to include a thorough assessment of the pain characteristics, also your vital signs, and immediate preparation for transportation, ensuring that potential surgical issues are going to be rapidly addressed for this. All right, so when receptors in the organs are stimulated, they send signals through the nervous system to the brain, where these impulses are interpreted as pain. So the process is especially relevant when we talk about visceral pain, which is the type most commonly associated with urologic issues. This is going to be such as problems with the ureters, the bladder, or the urethra. So visceral pain arises when receptors in these hollow structures are activated due to distension, irritation, or injury. We talked about a little bit in the last slide. So one of the key characteristics of visceral pain is its diffuse nature, like we talked about, right? You didn't forget. So it makes it difficult for patients to pinpoint the exact source. So this happens because fewer nerve fibers are involved in transmitting the pain signals. And this is going to lead to a more generalized sensation of discomfort. So visceral pain can also perceive sensations like touch, pressure, heat, cold, but it remains challenging to localize and compared to the parietal pain. So when a patient presents with generalized abdominal pain, especially if they describe it as cramping or intermittent, the critical decision for you is to consider if it's, again, visceral pain as a possible cause. So this could be such as from a urologic problem or a bowel distension, okay? So your next step should include asking focused questions about the nature of the pain, and then performing a thorough assessment and considering transport to rule out severe underlying issues. Keep in mind that diffuse visceral pain may mask a more serious problem that may need to require rapid intervention. All right, referred pain. So referred pain is a phenomenon that occurs when the visceral peritoneum is irritated, but the pain is perceived at a distant location in the body. We talked about this during cardiac, when we talked about cardiac issues and jaw pain, or issues and you feel pain and burning in your back, referred pain. So this happens because of the interconnectedness of the body's autonomic and somatic nervous systems. Essentially, pain signals originating from the internal organs can be misinterpreted by the brain as coming from other areas, such as the back or shoulder, due to the shared nerve pathways. For example, a patient with gallbladder inflammation may feel pain in their right shoulder rather than directly in the abdomen itself. So similarly, pain from a heart attack, like we just talked about, can radiate to the jaw or that left arm pain, right? So this overlap in nerve communication can make it challenging to identify the true source of the problem, and this is going to require careful assessment because of this. So think of these patients. When a patient reports pain in areas like a shoulder or back without any obvious injury to those areas, it's going to be important that you consider the possibility that, hey, this may be referred pain from an internal organ. So your decision-making focus you should focus on correlating the patient's symptoms with potential visceral sources, such as like a gallbladder or kidney issues. Your approach should include a detailed assessment asking about the abdominal symptoms and preparing for rapid transport to ensure that potentially life-threatening injury internally, or like a life-threatening internal condition, they're quickly addressed. So we want to make sure to stay on top of that. All right, peritonitis. We just talked a little bit about this. So that inflammation of the peritoneum, so typically in the ileus, so which is the paralysis of normal muscular contractions, peristalsis, right? So that peristalsis what that does, it propels material through the intestines. So when peristalsis stops, the stomach can no longer empty properly, leading to vomiting, right? This emesis. So vomiting is called emesis. That's the medical term, if y'all remember. So peritonitis is also associated with a loss of body fluids into the abdominal cavity, which can significantly reduce the volume can significantly reduce the volume of circulating blood and lead to hypovolemic shock. So this fluid shift is further going to be complicated if there is internal or external bleeding. This is going to severely reduce perfusion to vital organs, and it's going to exacerbate shock. So it's important to note that patients with peritonitis may initially have normal vital signs, though these signs of shock become much more evident if there's hemorrhage that's involved. So fever may or may not be present with these patients, depending on the underlying cause. So for example, patients with diverticulitis or cholecystitis, often they experience a substantial fever, whereas patients with appendicitis may not show a fever until the appendix ruptures and an abscess then starts to form. Renal and urologic diseases range from mild infections like urinary tract infections to severe emergencies such as a acute kidney injury, or an AKI. So your role in pre-hospital care for those type of conditions is largely going to be supportive, but recognizing the symptoms is going to be very crucial for a timely intervention in this. So many conditions, including those discussed here, can cause urinary retention, which is the inability to fully empty the bladder. All right, so these patients, if a patient presents with vomiting, abdominal distension, and signs of shock, the critical decision for you is going to be to recognize that the possibility of peritonitis with fluid loss or hemorrhage. So you got to focus on that monitoring for shock, providing that supportive care like your IV fluids, and then ensuring that rapid transport to a facility that can give them surgical intervention. So early recognition of this and being aggressive is what's going to do this in. All right, a table. So when assessing patients, if you're looking at this table, when assessing patients with abdominal pain, it's going to be important to be aware that the most common abdominal conditions and their associated symptoms, including where pain is likely to be felt, understanding the typical presentations of these conditions can help guide your initial assessment and your decision making from there. So, for example, appendicitis often presents with pain that starts near the umbilicus, and later localizes to the right lower quadrant, Cholecystitis, which is inflammation of the gallbladder, typically presents with pain in the right upper quadrant, and this pain can radiate to the right shoulder, so all the way up here. All right, this is going to be a classic case of referred pain that we talked about. So conditions like diverticulitis involve inflammations of small pockets in the colon, and they usually cause pain in the left lower quadrant, all right? Renal conditions such as kidney stones often present this severe cramping pain, or that colic. Cramping pain is colic. And that radiates from the flank to the groin, while a pancreatitis typically causes severe pain in the upper abdomen that radiates to the back. So understanding the common locations of both direct and referred pain is going to be important in narrowing down those potential causes of patient symptoms. All right, so when a patient presents with abdominal pain, your critical decision is to quickly assess the location and the quality of the pain. So you need to know the common patterns of abdominal conditions that can help you identify any life-threatening emergencies. So after your assessment, you're going to initiate that supportive care. Then you're going to do what? IV fluids for that patient to make sure that their hemodynamics or stay intact, right? Or the best we can to recover them. And then we're going to prioritize that rapid transport if there are any signs of serious signs of condition that's going to worsen up, and if they start to become present, we need to get on down the road. The abdominal cavity normally contains a very small amount of peritoneal fluid that bathes and lubricates the organs, helping them function as smoothly as it possibly can, right? It does a pretty good job. However, when foreign substances such as pus, blood, feces, urine, gastric juice, bile, pancreatic juice, or even amniotic fluid accumulate within or near the abdominal cavity, it can lead to peritonitis and acute abdomen. All right. So remember that acute abdomen is that fast onset of pain in the abdomen. So these substances cause irritation and inflammation of the peritoneum, which result in severe abdominal pain and potential complications. It's going to be important to understand that even organs that are located behind the peritoneum, such as the kidneys, ovaries, and other the genitourinary structures, like your retroperitoneal organs, can still cause acute abdomen because they lay adjacent to the peritoneum. So although they aren't directly inside the peritoneal cavity, inflammation or trauma to those organs can still lead to peritoneal irritation and pain. So nearly any abdominal condition, whether it's due to infection, trauma, and disease, can lead to an acute abdomen. So the key is going to be to recognize those signs and symptoms early to prevent those life-threatening issues. All right, gastrointestinal hemorrhage or GI hemorrhage. This is going to refer to bleeding within the GI tract, and it's a symptom of an underlying disease, not a disease itself. GI bleeding can be acute. So acute meaning that occurring suddenly and severely, right? Or it can be chronic, which is that longer in duration, but often it's going to be less intense. So regardless of the severity, all complaints of GI bleeding should be taken seriously. So what can happen is that signals a potentially life-threatening issue. All right, so GI bleeding can occur in either the upper or the lower GI tract. So the upper GI tract includes the esophagus, the stomach, and upper part of the small intestine. Common causes of upper GI bleeding are going to include esophagitis, esophageal varices, and Mallory-Weiss tears. So this can result in this hematoemesis, all right, which is that vomiting blood. So the lower GI tract extends from the small intestine to the anus, with bleeding that could result from bowel inflammation, diverticulitis, cancer, or hemorrhoids even. So blood in the lower GI tract may appear as melena. All right, this melena is dark, tarry stool. All right, and this is going to be due to the partial digestion of blood. So one example of a condition that causes upper GI bleeding is that esophagitis, right? So this is going to be inflammation of the esophagus. This inflammation can be caused by infections. It can also be caused by gastric reflux or this irritation from certain medications or treatments like chemotherapy. So patients with esophagitis typically present with complaints of heartburn or a sensation of choking due to the irritation and the swelling of the esophageal lining. All right, gastroesophageal reflux disease, or GERD, G-E-R-D. This is going to occur when the sphincter between the esophagus and the stomach becomes weakened or relaxed, allowing stomach acid to move back up to the esophagus. This condition is also known as acid reflux. Often it causes a burning sensation in the chest, commonly referred to as heartburn. All right, risk factors for GERD include smoking, obesity, and pregnancy, which all increase the likelihood of GERD pretty high, or this acid reflux pretty high. So over time, GERD can cause significant damage to the esophageal wall, particularly if the reflux is persistent. So this can lead to weakened areas in the esophagus that become more susceptible to bleeding. So in more advanced cases, patients may present with hematoemesis, this vomiting blood, or melena, that dark tarry stool, due to the damage that's caused by the acid. So heartburn is the most common symptom of GERD, and it often worsens when the patient is lying flat. So sitting upright tends to relieve that discomfort. So while heartburn is not a typical sign, some patients may not experience pain, but they may instead have a chronic cough or difficulty swallowing. The stomach and the duodenum are exposed to high levels of acidity as part of the digestive process, right? To prevent damage from these acids, both organs are lined with these protective layers of mucus. However, when these protective layers erode, peptic ulcer disease, or PUD, or gastritis can develop. In peptic ulcer disease, the erosion of the protective layer, it allows stomach acid to eat into the lining of the stomach or the small intestine, creating ulcers over weeks, months, or even years. So gastritis, on the other hand, is the pre-ulcerative condition where the stomach becomes inflamed, but the erosions that cause ulcers have not yet been formed. So peptic ulcers are often caused by infections with the Helicobacter pylori bacteria, or H. pylori bacteria, or the chronic use of non-steroidal anti-inflammatory drugs, NSAIDs, right, like your ibuprofen, stuff like that, which are going to damage the mucosal lining of the stomach, and this can lead to ulcers. Also, alcohol consumption and smoking can contribute to the development and the severity of those conditions. So if the patient presents with upper abdominal pain, especially after meals accompanied by a history of NSAID use or alcohol consumption, it's going to be important to consider the possibility of peptic ulcer disease or gastritis. So from there, you need to monitor for signs of gastrointestinal bleeding, such as that hematemesis or that melena is going to be very crucial for this. All right, and from there, we're going to do that supportive care, preparing for transport. We're going to assess the extent of the ulceration or the inflammation. If it's going to be very important that we do this, because if a perforation happens, it could cause severe bleeding. We definitely don't want that. All right, peptic ulcer disease, or PUD. This is going to affect both men and women equally. Though it's more common in older adults, the same factors that cause PUD, such as the H. pylori infection, chronic NSAID use, alcohol consumption, and smoking, it can also cause gastritis. So additionally, foodborne infections and food allergies can trigger inflammation of the stomach. Patients with peptic ulcers or gastritis often experience a sequence of burning or gnawing pain in the stomach. This pain is it's going to subside after eating, but it reemerges 2 to 3 hours later, okay? So the pain is usually felt in the upper abdomen, or it's going to be just below the sternum, although some patients may feel pain immediately after eating. So common symptoms also are going to include nausea, vomiting, belching, and heartburn for this. So in more severe cases, ulcers can lead to gastric bleeding, which may result in hematemesis, that vomiting blood, or that melena, that dark tarry stool. So while some ulcers heal on their own, complications such as bleeding or perforation of the stomach lining can occur, and severe cases may cause peritonitis and acute abdomen, both of which are going to be very life-threatening. All right, a Mallory-Weiss tear is a tear that occurs at the junction between the esophagus and the stomach. So this condition can cause severe bleeding, and in extreme cases, it can be life-threatening if it's not treated promptly. The most common risk factors for developing Mallory-Weiss tear, it includes chronic alcoholism and eating disorders. However, the condition can occur in individuals of any age. So the hallmark symptom of a Mallory-Weiss tear is vomiting, which may be accompanied by blood, that hematemesis. So in some cases, particularly in women, this syndrome may be related to severe vomiting associated with pregnancy. So the extent of bleeding can vary from minor to pretty severe. All right, and this can lead to significant fluid loss. So in severe cases, patients may present with signs of shock, upper abdominal pain, and melena, which we know as a dark tarry stool. All right, so in these patients, they may present with this sudden vomiting, followed by that hematemesis, or that hematemesis. All right, so especially if they have a history of alcoholism or an eating disorder, it's going to be important that we consider that Mallory-Weiss, right? That Mallory-Weiss type tear as the cause. So we're going to assess the signs for shock. We're going to assess low blood pressure, that rapid heart rate, and prepare for rapid transport if the bleeding is severe. So if they have any of that, then we know that we're going to start IV fluids, right? You see that trend that every patient needs IV fluids and good transport. Boerhaave syndrome is a rare but life-threatening condition that occurs during episodes of severe vomiting. Similar to a Mallory-Weiss tear, however, in Boerhaave syndrome, the esophagus tears longitudinally, right? And the tear, it travels through the entire wall of the esophagus. So this creates an opening through which blood, air, and food can leak out. All right, so it leaks out of the esophagus, and it can actually leak out into the mediastinum. So that's the mediastinum is that central compartment of the chest, if you remember. And if it leaks out into that area, it can lead to severe complications like infection or sepsis even. So this condition tends to occur more often in men, particularly after they have a large meal that included alcohol consumption also. So the symptoms can be sudden and they can be severe. The rapid identification is going to be very important for this due to the high risk of complications that's involved. All right, so if a patient presents with a severe chest pain following violent vomiting after a large meal, especially with a history of alcohol consumption, consider Boerhaave syndrome. The critical focus in this should be on assessing for signs of shock or sepsis and stabilizing that patient. Airway management and rapid transport are going to be crucial since this condition can quickly lead to life-threatening infections and other complications due to the leakage of food and air and fluids into the mediastinum that can cause a lot of problems on its own. Esophageal varices occur when the pressure within blood vessels surrounding the esophagus increases. Often, this is going to be due to blocked blood flow in the liver. So these esophageal vessels, normally they drain blood into the liver, but when blood backs up into the portal vessels, the vessels dilate, and this causes the capillaries in the esophagus to leak. If the pressure continues to build up, the vessel walls may rupture. And this is going to lead to a massive upper gastrointestinal bleeding and the hematoemesis, that vomiting blood. So in industrialized countries, alcohol consumption is the leading cause of portal hypertension, which can lead to this esophageal varices. So patients typically present in two different ways. So you got initially they show signs of liver disease, such as fatigue, weight loss, jaundice, anorexia, abdominal pain, and swelling from that edema. So this gradual process can take months or even years before the patient feels any type of extreme discomfort. So the second presentation is far more acute, and it's far more life-threatening. So when esophageal varices rupture, patients may experience sudden discomfort in the epigastric region, okay, or behind the sternum. So this is going to be severe difficulty swallowing they're going to have, and vomiting of bright red blood. So hypotension and signs of shock may follow pretty quickly with this, right? Makes sense because a bright red blood is coming out. All right, so even smaller bleeds can present with this hematoemesis, right? That hematoemesis is that vomiting blood, and then that melena is going to be that dark tarry stool. All right, but regardless of the bleeding rate, this condition is a medical emergency at this point. So when a patient presents with sudden hematoemesis or signs of shock, especially with a history of alcohol use or liver disease, suspect esophageal varices. So that immediate attention should be to focus on managing shock and preparing for rapid transport. So severe variceal ruptures can lead to death in minutes. Heck, it can happen very quickly. So controlling the airway and then that fluid loss, controlling that is going to be essential for that patient's survival. All right, hemorrhoids are swollen and inflamed blood vessels in the rectum. a common condition that affects nearly half of the people by the age of 50. Half of people by the age of 50. That's a lot of people. So these can be caused by conditions that increase pressure or inflate the rectum, such as when we're talking about like pregnancy, straining during bowel movements, chronic constipation, or even diarrhea, which can irritate the rectal tissues. So the most common symptom of hemorrhoids is bright red blood during defecation. All right, what we call hematochezia. Okay, so the bleeding is typically minimal and it's easy to control. In addition to bleeding, patients may report itching around the rectal area and the presence of a small mass. So this mass is often a clot. It's formed in response to mild bleeding within the hemorrhoid. So while hemorrhoids are usually not life-threatening, they can cause discomfort and anxiety for patients, especially if they notice blood in their stool, right? It could freak people out. So when a patient presents with bright red blood during defecation and reports itching or a small mass around the rectum, we need to consider hemorrhoids as the likely cause for this. So while the bleeding is typically minor, it's important to rule out more serious conditions. If the patient experiences significant discomfort or other symptoms, offering supportive care and advising them to seek follow-up help is going to be very important. So ensuring the patient understands that hemorrhoids can be managed with lifestyle changes or medical treatment may help to alleviate their concerns. Gallstones. So gallstones are a common non-hemorrhagic condition. All right, so this occurs when hard deposits form in the gallbladder, which is a storage pouch for digestive juices and waste for the liver, or from the liver, not for the liver, but from the liver. So these stones, they can block the outlet of the gallbladder, leading to significant pain, right? So in some cases, the blockage may pass on its own, relieving the discomfort. However, if the blockage persists, it can cause inflammation of the gallbladder, which is going to be a condition known as cholecystitis. All right? So inflammation of the gallbladder, cholecystitis. So cholecystitis can lead to intense pain in the right upper quadrant of the abdomen and may radiate to the right shoulder. So patients may also experience nausea, vomiting, and fever. If untreated, cholecystitis can cause serious complications such as infection or rupture of the gallbladder. So when a patient presents with sudden, severe right upper quadrant pain, especially after eating fatty foods, we need to consider the possibility of gallstones or cholecystitis. We're going to assess for associated symptoms like fever or referred pain in the right shoulder. If the pain is unrelenting, the preparation for transport is going to be crucial, as untreated cholecystitis, it can lead to life-threatening complications. So during this time, we're going to monitor for signs of infection and providing supportive care that will help stabilize the patient until definitive treatment can be provided. In severe cases, gallstones can lead to a rupture of the gallbladder. This is allowing inflammation to spread and irritate surrounding structures like the diaphragm and the bowel. So this is going to result in a constant severe pain in the right upper or mid-abdominal region. So this may radiate to the right upper back, the flank, or the shoulder. So the pain can either steadily increase over several hours or come and go intermittently. Symptoms of gallstones and cholecystitis typically appear about 30 minutes after consuming a particularly fatty meal and often occur at night. Patients may also experience general gastrointestinal distress, including nausea, vomiting, indigestion, bloating, gas, and frequent belching can happen. So these symptoms, along with the pain pattern, are key indicators of gallstone involvement. So when we're assessing a patient with severe right upper quadrant pain, particularly after eating that fatty meal and associated GI symptoms, we're going to consider the possibility of a gallbladder rupture or cholecystitis. So we need to pay attention for referred pain in the shoulder or the back, as this can suggest the spread of inflammation, right? So immediate intervention and rapid transport are going to be important for this if gallbladder rupture is suspected, as this condition can lead to peritonitis and life-threatening complications if it's left unchecked. So we're going to stabilize the patient, supportive care, while preparing for definitive treatment for these patients. The pancreas is responsible for producing digestive juices and insulin, which regulate blood sugar levels, right? If you remember that from a few slides back. So when the pancreas becomes inflamed, when the pancreas becomes inflamed, the condition is known as pancreatitis. Now remember, anything inflamed usually has itis on the end, right? So pancreatitis in this case. This inflammation, it can be triggered by several different causes, okay? So this can include an obstruction or an obstructing gallstone. It can be chronic alcohol abuse or a plethora of other underlying diseases. So pancreatitis can cause severe abdominal pain, often radiating to the back, and it may be accompanied by nausea, vomiting, and abdominal distension. So the pain typically worsens after eating and may be constant or come in waves. In severe cases, pancreatitis can lead to complications such as infection, bleeding, or even shock. So when a patient presents with severe, persistent abdominal pain radiating to the back along with nausea and vomiting, pancreatitis should be considered in this, particularly if there's a history of alcohol use or gallstones. So close monitoring of that patient's vital signs is going to be important, as severe cases can lead to shocks. So rapid transport is going to be necessary for that, right? So as pancreatitis can lead to life-threatening complications if it's not treated promptly, we need to make sure that we're aggressive with this. So providing that supportive care while preparing for advanced medical intervention is going to be key for your pancreatitis patient. So pancreatitis, like we talked about, presents with this distinct set of signs and symptoms, okay? So patients often experience that severe pain in the upper left and right quadrants of the abdomen, which frequently radiate to the back. So that nausea, vomiting, and abdominal distension and tenderness in the abdomen are going to be common for that, right? So the pain tends to worsen after eating, and it can be persistent or intermittent, all right? Just to review. So complications from pancreatitis can also be serious. So sepsis and hemorrhage are potential life-threatening outcomes for this. So it's important to monitor the signs such as fever or tachycardia. These complications may indicate the condition has progressed and it requires immediate medical intervention if so. All right, appendicitis. So appendicitis is an inflammation or an infection of the appendix. So a small recess in the large intestine is where the appendix is going to be at. So it is a frequent cause of acute abdomen and can lead to serious complications if it's left untreated. So these include tissue death, rupture, abscesses, or that abscess formation, peritonitis, and it can even cause shock. So the pain associated with appendicitis usually starts as a generalized, dull, and diffuse discomfort, often centered around the umbilical area. So as the condition starts to worsen, the pain localizes to the right lower quadrant of the abdomen. It can also cause referred pain in other areas of the body. So patients may report nausea, vomiting, loss of appetite, anorexia, fear, and chills. A classic symptom of appendicitis is rebound tenderness, which is going to occur due to the peritoneal irritation. So this can be assessed by gently pressing down on the abdomen and releasing the pressure. If the patient experiences more pain upon the release, this is indicative of this rebound tenderness we were talking about. However, it's important to note that women who are pregnant may not always exhibit this symptom. So when assessing a patient with abdominal pain that has shifted to the right lower quadrant and it's accompanied by nausea, fever, chills, we're going to consider this appendicitis. So we're going to look for rebound tenderness as a sign of peritoneal irritation, and we're going to be aware that the condition could lead to these serious complications if it's not treated promptly. So rapid transport is going to be crucial for this patient to prevent any type of rupture or shock, and supportive care should focus on stabilizing the patient while preparing for this surgical intervention. All right, gastroenteritis. So gastroenteritis refers to a group of conditions that cause inflammation of stomach and intestines, typically resulting in diarrhea, nausea, and also it can cause vomiting. So it's most commonly caused by bacterial or viral infections, which are usually contracted through contaminated food or water. The onset of symptoms can range from a few hours to several days after contact with the contaminated source. So patients often present with an upset stomach, diarrhea, and sometimes vomiting. The disease may resolve within 2 to 3 days, but it can last for weeks. And this is going to be depending on the severity of the case, all right, or the severity and the cause of it, more so. So infectious gastroenteritis is usually caused by organisms like salmonella or norovirus, while non-infectious gastroenteritis can result from adverse reactions to medications, exposure to toxins, or chemotherapy. In both infectious and non-infectious forms of gastroenteritis, diarrhea is the primary symptom. So other symptoms such as abdominal cramping, dehydration, and fatigue are also common, particularly in prolonged cases of gastroenteritis. It's going to be important to recognize those signs early to prevent any type of complications, particularly in dehydration, or particularly that dehydration complication. We want to be able to mitigate that. So when a patient presents with vomiting and diarrhea, especially after potential exposure to contaminated food or water, gastroenteritis should be considered for this. So we're going to monitor for those signs of dehydration, such as dry mucous membranes, decreased urine output, or poor skin turgor. That's going to be important. So hydration and symptom control are going to be key aspects of care. And if the patient shows signs of severe dehydration or inability to retain fluids, rapid transport to a healthcare facility is going to be definitely recommended for fluid replacement therapy. All right, gastroenteritis, like we talked about, is that inflammation of the stomach and the intestines that leads to diarrhea, nausea, and vomiting. It's typically caused by that bacterial or viral infections, which are contracted through that contaminated food or water, right? Though non-infectious causes like medications reactions and toxin exposure are also possible with these, right? If you remember. So symptoms can appear within hours to days after exposure, and the illness may last anywhere from a couple of days to several weeks for this. So patients often experience either large dumping type diarrhea or frequent small liquid stools. In more severe cases, the diarrhea may contain blood or pus even. So additionally, symptoms include abdominal cramping, nausea, vomiting, fever, and anorexia. So while most cases resolve on their own, the primary concern for prolonged diarrhea is dehydration. So as fluid loss continues, patients can become dehydrated, and this leads to symptoms such as dry mucous membranes and decreased urine output. So if dehydration worsens, the likelihood of hypovolemic shock increases, which is going to require immediate medical attention. Recognizing those signs of severe dehydration and monitoring the patient's fluid status is going to be essential to prevent any further complications down the road. So if you have a patient that presents with significant diarrhea or nausea and vomiting, we want to, especially when we're talking about an exposure to contaminated food or water, gastroenteritis should be considered for this. So that early recognition of dehydration is what is actually going to be important for that. All right, so we're going to monitor for symptoms like that poor skin turgor and that tachycardia. So if the patient cannot retain fluids or show signs of worsening dehydration, fluid resuscitation and rapid transport to an advanced care are going to be prioritized to prevent shock from gastroenteritis. Diverticulitis is a condition that became more common around the 1900s, coinciding with significant changes in dietary habits, particularly a sharp decrease in fiber intake and an increase in processed foods. Fiber helps keep stool soft and easy to pass, but as the amount of fiber in a diet is decreased, stool becomes more solid, requiring stronger contractions of the intestines. So this increased pressure in the colon led to the formation of these small bulges in the colonic walls. So this is known as diverticula. So over time, these diverticula can become problematic. Fecal matter may become trapped in the bulges, allowing bacteria to grow in there, which is going to lead to that localized inflammation and infection. So this is going to be a condition known as diverticulitis. So this infection can cause severe pain, typically in the lower left quadrant, along with the symptoms such as fever, nausea, and changes in bowel habits. So this can include constipation or diarrhea. So diverticulitis can lead to complications like abscesses, abscess formations, or perforation of the colon, which can cause peritonitis, which is also a life-threatening condition, right? So when assessing a patient with lower abdominal pain, particularly in the left lower quadrant, and associated symptoms like fever or changes in bowel habits, the diverticulitis should be considered. So monitoring for signs of systemic infection or complications such as peritonitis is going to be very critical. If the patient shows signs of worsening infection, including tachycardia or hypotension, right? Rapid transport and fluid resuscitation may be necessary to prevent septic shock. So diverticulitis occurs when those small pouches, that diverticula, they have formed in the walls of the colon and become inflamed and infected, right? So this condition is probably caused by that low fiber diets, if you remember. Okay? So this is going to lead to this increased pressure in the colon as it works to move solid stool. So the main symptom of diverticulitis is what? Abdominal pain. So typically located on which side? It's going to be the left side of the lower abdomen. So patients may present with classic signs of infection, including fever, malaise, body aches, chills, nausea, vomiting. While bleeding is rare in diverticulitis, other complications such as adhesions may develop, which can narrow the colon, and it can lead to constipation or bowel obstruction. So in severe cases, the infected diverticula can rupture, causing perforation of the colon. So this can result in peritonitis, which is going to be that severe and potentially life-threatening infection that can decrease to septic shock, or that can, I'm sorry, not decrease, but this can progress into septic shock. And if it's left untreated, that's exactly what will happen. So recognizing the signs of diverticulitis early is crucial to prevent these serious complications from happening. So when a patient presents with lower left abdominal pain, fever, and systemic signs of infection, diverticulitis should be strongly considered for this. So be alert for potential complications such as a ruptured diverticulum, which can lead to peritonitis. So monitoring the patient's vital signs and assessing for signs of key signs of shock is going to be very key. Rapid transport is also going to be absolutely critical for this, especially if the patient shows signs of systemic infection or septic shock. So that what we're looking for in that septic shock is going to be tachycardia or hypotension. All right, ulcerative colitis. So ulcerative colitis is a chronic inflammatory condition that affects the colon, specifically the inner lining of the intestine. Unlike Crohn's disease, which occurs in patches, the inflammation in ulcerative colitis is more generalized. So the exact cause of the inflammation is unclear, though genetics, stress, and autoimmunity are believed to play a pretty big role in this. So this chronic inflammation causes thinning of the intestinal wall, which leads to weakening and dilation of the rectum. So in the United States, approximately 238 out of every 100,000 people are affected by ulcerative colitis, with a higher occurrence in men than the occurrences of women. So the disease may also, it also has a strong familial, like the familial, your inner family, that component is pretty strong there. So this makes family history an important factor during assessments. So signs and symptoms of ulcerative colitis typically develop gradually. So patients may present with bloody diarrhea, that hematochezia, and ranging from mild to severe abdominal pain, and may also experience joint pain and skin lesions as well. So in more advanced cases, the patient can develop fever, fatigue, and loss of appetite due to the underlying infection and inflammation. All right, so If you have a patient with a history of bloody diarrhea, abdominal pain, and signs of systemic infections such as fever and fatigue, ulcerative colitis could be considered in this case. So the gradual onset of symptoms such as chronic inflammation, we need to look at that. So be vigilant for signs of dehydration and shock, particularly in patients that have a significant fluid loss through diarrhea. So early intervention for this and fluids is what's going to be important. It's going to win the game and getting them there, right? Getting them to the hospital. All right, irritable bowel syndrome, or IBS. It's a chronic condition characterized by abdominal pain and changes in bowel habits. For diagnosis, patients must experience pain at least 3 days per month for a minimum of 3 months. So the exact cause of IBS, it remains unclear, but 3 key factors are commonly observed. You have hypersensitivity of bowel pain receptors, you get hyperresponsiveness of the smooth muscles in the bowel, and a potential connection to psychiatric disorders. It is uncertain whether the psychiatric issues cause IBS or vice versa. In IBS, hyperresponsiveness of the bowel can lead to spasms, causing either constipation if fecal movement is halted or diarrhea if the spasms are wave-like. So patients often experience abdominal pain that's relieved after a bowel movement. Symptoms typically begin in childhood and can be triggered by stress, large meals, or certain foods like wheat, dairy, caffeine, and alcohol. So patients may present with diarrhea, constipation, steatorrhea, or that fatty stools, bloating, or general discomfort as well. So while IBS is not life-threatening, it can significantly impact the quality of life for your patients. So when evaluating a patient with a history of chronic abdominal pain and irregular bowel habits, IBS should be considered for this. So identifying possible triggers such as stress or dietary factors is going to be important in managing your symptoms. So although IBS is not an emergency condition, providing reassurance and advice on the symptom is going to be very important. So you need to reduce stress where you can, and also tell them what foods to avoid to keep from triggering this issue. Disease is a chronic inflammatory condition similar to ulcerative colitis, but it can affect any part of the gastrointestinal tract, from the mouth to the anus. The ileum part of the small intestine is most commonly affected. So while the exact cause is unknown, genetics and family history play, again, a significant role in the development of the disease. So an autoimmune component is also believed to contribute, as signs and symptoms often appear outside the GI tract, indicating a systemic type immune response. So Crohn's disease affects approximately 201 adults per 100,000 people, with the most patients diagnosed between the ages of 15 and 35. There is also a notable incidence among other adults aged 60 to 70. So the disease is more common in Caucasians than in African Americans, and individuals of Jewish descent have a significantly higher incidence. So in Crohn's disease, white blood cells attack the GI tract, damaging all layers of the affected area. This leads to scarring, narrowing, stiffening, and weakening of the intestines. Patients commonly experience chronic abdominal pain. Often it can be localized to the lower right area, all right, along with the diarrhea, the weight loss, and the fatigue. So, if you're assessing a patient with chronic lower right abdominal pain and a history of gastrointestinal issues, Crohn's disease should be considered for this. So be alert for signs of systemic involvement such as joint pain or skin lesions, which are going to suggest an autoimmune component to this. Though Crohn's disease is not typically life-threatening, complications such as bowel obstructions or perforations can occur with this. So rapid transport is going to be necessary in cases of severe abdominal pain or suspected complications like intestinal perforation. All right, the renal and urologic systems are essential for filtering waste and maintaining fluids and electrolyte balance in the body. Diseases and conditions affecting these systems can cause a wide range of symptoms, including acute abdominal pain, okay? So these conditions range from mild, such as urinary tract infections, UTIs, to true medical emergencies, such as an acute renal failure. So urinary tract infections often present with symptoms like dysuria. Painful dysuria is going to be that painful urination. And then you have the increasing frequency of urination and lower abdominal pain. So while uncomfortable, UTIs are typically manageable and are rarely life-threatening. So on the other hand, conditions like acute renal failure, where the kidneys lose their ability to filter waste, can lead to serious complications, including fluid retention, electrolyte imbalances, and life-threatening organ failures. So pre-hospital care for most renal and urologic conditions is going to be supportive, focusing on pain management and monitoring vital signs. However, it's going to be critical to recognize signs of true emergencies. For example, symptoms like severe flank pain, gross hematuria, that blood in the urine, or signs of shock may indicate more serious issues such as kidney stone, pyelonephritis, or acute renal failure. Okay, so if a patient with acute in patients with acute abdominal or flank pain, identifying potential renal or urologic emergencies is going to be very important for you. So when assessing a patient, look for key symptoms such as decreased urine output, gross hematuria, or signs of shock, which may indicate severe kidney or urinary tract involvement. So supportive care, including IV fluids, all right, you're going to be given those IVs, and pain management can help stabilize the patient while preparing for rapid transport to advanced care. All right, urinary tract infections known as bladder inflammation or cystitis are going to be common infections that usually develop in the lower urinary tract. And this is going to affect the urethra and the bladder. So UTIs occur when bacteria enter the urethra and grow in the urinary tract. So this condition is much more common in women due to their shorter urethra, which allows easier access for bacteria, right? So if a lower UTI is left untreated, the infection can spread to the upper urinary tract. And this can affect the ureters, the kidneys, and this can also lead to more severe conditions like pyelonephritis and kidney abscesses. So when the kidneys are involved, kidney function can be impaired and the risk of complications increase. In elderly patients, untreated UTIs are particularly going to be dangerous as they lead to sepsis. So sepsis is a life-threatening systemic infection. So symptoms of lower UTIs typically include painful urination, dysuria, frequent urges to urinate, which would be polyuria if they're urinating frequently, would be polyuria, and lower abdominal or pelvic pain. So when the infection spreads to the upper urinary tract, patients may experience flank pain, fever, chills, and more severe systemic problems, more severe systemic symptoms. So, something to know about pyelonephritis is that it starts off in the umbilical area, and then as it gets worse, it moves down into the right, into the flank, all right, or to the flank. Maybe not so much which way or the other, but I know it moves to the flank. So that can be an issue. So, when a patient presents with dysuria, frequent urination, and lower abdominal discomfort, a UTI should be considered. We want to make sure that we're alert for signs of a more severe infection, such as flank pain, because it moves to the flank, and then fever or changes in mental status in elderly patients, which may indicate pyelonephritis or sepsis. So providing supportive care and ensuring rapid transport to prevent progression to kidney damage or sepsis is going to be important. Lower urinary tract infections, or UTIs, again, are typically present with a range of symptoms that include that painful urination, that dysuria, frequent urges to urinate. We talked about all this, right? And difficulty starting or maintaining a urine stream as well. So the pain associated with UTI often begins as a visceral discomfort, but can quickly become an intense burning sensation, particularly during urination. So this pain is usually localized to the pelvic region and is often perceived as bladder pain in women or prostate pain in men. In some cases, referred pain may occur in the shoulder or the neck, although this is less common for this. So in addition to pain, patients with a lower UTI may notice that their urine has a foul odor or appears cloudy. So both of which are going to be indicative of a bacterial infection. So these symptoms, while uncomfortable, are typically manageable with treatment, okay? But if they're left untreated, they can progress into a more severe condition, such as having an upper urinary tract infection, which we talked about in the last slides, that it can cause a litany of problems. So when encountering a patient with a painful urination or frequent urination and pelvic discomfort, a lower UTI is probably likely. So look for additional symptoms such as that cloudy or foul-smelling urine to confirm your suspicion. So early treatment and monitoring for signs of worsening infections such as flank pain or fever can be essential to prevent progression to a more serious infection like pyelonephritis. So providing supportive care and ensuring appropriate transport can help mitigate those risks of that. So kidney stones, also known as renal calculi, form in the renal pelvis when excess insoluble salts or uric acid crystallize in the urine. So these crystals accumulate, forming stones that can be various sizes. So the primary cause of kidney stones is insufficient water intake, right? Which prevents the salts from dissolving properly, allowing them to form solid masses. So as kidney stones grow, they can obstruct the flow of urine. And this leads to an intense pain, particularly when the stones pass through the ureters. So the pain is typically severe, sharp, and located in the flank area, all right, radiating to the groin as the stone starts to move. So in addition to pain, patients may experience nausea, vomiting, hematuria, blood in the urine, right, and difficulty urinating. So without sufficient hydration to dissolve those salts, kidney stones become a painful and potentially recurrent issue for many patients. So when assessing a patient with severe flank pain radiating to the groin, accompanied by nausea, vomiting, and hematuria, kidney stones should be the primary consideration for this. So monitoring the patients for signs of dehydration and managing pain are going to be the key to providing supportive care for this. So rapid transport may be necessary if the stone causes significant obstruction or the pain is unmanageable. So as further medical intervention may be needed for this, we just need to make sure that we're doing the best we can to diagnose and then get them out of there, get them to surgery so it can be removed. All right, kidney stones are a common cause of that severe flank pain. So with calcium stones being the most frequent type. So these stones are common in men, or they're more common in men than they are in women, and they may have a hereditary component. So patients with metabolic disorders such as gout or hormonal imbalances are also at higher risk for developing kidney stones. So the pain from kidney stones is typically intense, and it starts off as a vague discomfort in the flank before becoming more severe within 30 to 60 minutes. So as the stone moves through the urinary tract, the pain often migrates towards the groin, like we talked about in the last slide. So patients may respond to that pain in different ways. Some may be agitated and restless, moving frequently in an attempt to alleviate discomfort, while others may remain still and guard the abdomen, guarding. All right, so both behaviors can make palpation very difficult, and vital signs will often reflect the severity of pain. So with elevated blood pressure and heart rate, that's what we're talking about by that reflection of that pain. So if the stone becomes lodged in the lower ureter, patients may present with symptoms similar to urinary tract infection, that UTI. So you may have that painful urination, though fever is not usually present. So a thorough patient and family history can help identify a predisposition for kidney stones or kidney disease. Kidney disease can be categorized as either acute or it can be chronic, with chronic kidney disease affecting approximately 14% of the U.S. population. So the two leading causes of chronic kidney disease are going to be high blood pressure and uncontrolled diabetes. So, with your patients, if a patient presents with severe flank pain radiating towards the groin, kidney stones should be strongly considered for this. Agitation or guarding behaviors that may complicate the assessment, so monitoring vital signs for elevated blood pressure and heart rate is going to be very crucial in this. So if symptoms suggest obstruction or severe pain, rapid transport for further medical evaluation is going to be needed in these patients. Additionally, understanding the patient's medical history can help determine if there's a risk for chronic kidney disease, especially in patients with hypertension and diabetes, or hypertension or diabetes. Acute kidney injury, AKI, is characterized by a sudden decrease in the kidney's ability to filter waste from the blood, leading to a dangerous buildup of toxins. This condition can develop rapidly, but it is often reversible. If we diagnose and we treat it promptly, that's how we get it reversed, right? So one of the key signs of AKI is a drop in urine output. When urine output falls below 500 milliliters per day, the condition is called oliguria. All right, oliguria. So if the urine production stops entirely, it's known as anuria. All right, so anuria makes sense, right? A meaning nothing. AKI can cause a range of symptoms, including generalized edema. Due to a fluid retention, it can also cause this acid buildup in the blood, known as acidosis, and elevated waste products like urea and creatinine. If left untreated, the condition can progress to more severe complications such as heart failure, hypertension, and metabolic acidosis. The rapid onset of AKI makes early recognition essential. Patients may present with symptoms such as swelling, shortness of breath, fatigue, and changes in urine output. Understanding these signs and symptoms of AKI is going to be important to preventing life-threatening complications from happening. So, when you're assessing a patient with signs of fluid retention, decreased urine output, or sudden changes in mental status, we need to consider acute kidney injury. So monitoring for oliguria or anuria, along with symptoms like generalized edema or shortness of breath, is going to be key for early identification, not prevention. So prompt transportation and supportive care can help prevent the progression and life-threatening complications, such as when we're talking about like your heart failure or severe metabolic acidosis. All right. Chronic kidney disease, or CKD. Chronic kidney disease is a progressive and irreversible condition that occurs when the kidneys gradually lose their ability to function due to the permanent loss of nephrons. The kidney's filtering units, okay, that's what nephrons are. So this decline in function, it's gonna happen over months or years, and often the result of systemic diseases such as diabetes or hypertension. Which those things are going to place an excessive amount of strain on the kidneys themselves. CKD can also be caused by congenital disorders, prolonged infections like polynephritis, or secondary effects of certain infections such as untreated strep throat. So, as kidney function diminishes, the body becomes less efficient at filtering waste, balancing fluids, or regulating electrolytes, leading to complications such as anemia, hypertension, and metabolic imbalances. Because CKD develops slowly, patients may not notice the symptoms until significant damage has occurred. So early detection and management of the underlying cause are going to be important to slowing the progression of the disease. So when you're evaluating a patient with a history of diabetes or hypertension, consider the possibility of a chronic kidney disease, especially if they present with signs of fatigue, fluid retention, or difficulty managing blood pressure. Monitoring kidney function through lab values and being aware of early symptoms can help guide treatment and prevent further complications for these patients. So again, this rapid transport and supportive care may be necessary in CKD because if it has led to severe symptoms such as electrolyte imbalances or heart failure, so we need to make sure we're quick about this, right? All right, so we know chronic kidney disease, or CKD, it leads to progressive loss of kidney function as nephrons become damaged and cease to function. So over time, this damage causes the scarring in the kidneys, reducing their ability to filter waste and regulate fluids in the body. So as kidney function declines, waste products and excessive fluids build up in the bloodstream, leading to a range of systemic complications. Patients with CKD may develop hypertension, congestive heart failure, anemia, significant electrolyte imbalances as the disease starts to progress. So these complications, they occur due to the kidney's reduced ability to maintain those normal fluid and electrolyte balances. And this leads to increased strain on the cardiovascular system and other organs. So early detection in this is going to be important for these patients to slow down the progression for it. All right, so here's a list of signs and symptoms for this renal system, for the issues that you may see in the renal system. So as chronic kidney disease, CKD, progresses, patients may experience a variety of these signs and symptoms due to the accumulation of waste products and fluid imbalances in the body. In advanced stages, the patient may present with altered levels of consciousness, and in severe cases, seizures or coma are even possible. So early signs are going to include lethargy, nausea, headaches, cramps, signs of anemia such as pale and cool skin. So a characteristic feature in late CKD is the development of uremic frost. So this is going to be a powdery accumulation of uric acid on the skin, particularly on the face. Other symptoms include bruising, muscle twitching, and significant edema in the extremities and face due to fluid imbalances. So patients are often hypotensive with a rapid heart rate, this tachycardia, and may develop complications such as pericarditis, which is that inflammation of the lining around the heart, the pericardium, right? So they may also present with pulmonary edema. So the treatment of CKD involves substantial healthcare costs, okay? Particularly in advanced stages where patients may require dialysis or other life-sustaining interventions to keep them pushing through. So if patients with CKD, you got to be vigilant for severe symptoms like that altered mental status, seizures, or that uremic frost that you see a lot of times around their face or it's on the skin. So this is going to indicate a critical condition. Hypotension and tachycardia can signal worsening of the fluid imbalances, so providing supportive care and preparing for rapid transport are going to be key for you. Early recognition of the symptoms like pulmonary edema or pericarditis is going to be very important in managing those life-threatening complications. All right, end-stage renal disease, or ESRD, is the final stage of chronic kidney disease, CKD, or untreated acute kidney injury, AKI, in which the kidneys lose most or all of their ability to function. In ESRD, the kidneys can no longer filter waste products from the blood, leading to the buildup of toxic substances. So without intervention, this buildup leads to systemic failure. Patients with ESRD experience severe complications due to the accumulation of waste materials, fluid imbalances, and electrolyte disturbances. Symptoms of ESRD include lethargy, confusion, shortness of breath, and widespread edema. In this stage, the only options for treatment are regular dialysis or kidney transplantation, as the kidneys are no longer capable of sustaining life on their own. So ESRD is a fatal condition if it's left untreated. This highlights the importance of early detection and management of CKD and AKI to prevent progression to this stage. So if you're a patient with known ESRD, it's important to assess for signs of worsening fluid overload. So also with electrolyte imbalances or cardiovascular complications. If the patient has missed dialysis sessions or presents with symptoms such as confusion, lethargy, or shortness of breath, immediate transport to a dialysis center or a hospital is going to be critical for this patient. So monitoring those vital signs closely and providing supportive care can help stabilize the patient while awaiting definitive treatment. End-stage renal disease presents with a wide range of signs and symptoms as the kidney lose their ability to filter that waste, right? Like we talked about, leading to that toxic buildup in the body. So early signs are going to be this confusion, shortness of breath, peripheral edema, chest pain, and bone pain. So as toxins accumulate further, patients may experience pruritus, which is itching, or nausea, vomiting, muscle twitching, tremors, and hallucinations even. So patients often present with lethargy, headaches, muscle cramps, and anemia. So the skin may appear pale, cool, and moist, and could develop a jaundiced or a bruised appearance. Uremic frost is going to be that powdery residue of uric acid, and it may form around the face, right? So significant edema of the extremities and face is also going to be common, and this signals that severe fluid retention. So as the condition progresses, patients typically exhibit hypotension, tachycardia, and may develop pericarditis, right? Or that pulmonary edema. So in late stages, ESRD can lead to seizures, coma, and eventually death if it's not treated. So when evaluating a patient with ESRD, it's going to be crucial to monitor for that fluid overload, cardiovascular complications, and worsening toxicity, such as confusion or hallucinations. If symptoms of pericarditis or pulmonary edema are present, then immediate transport is going to be very critical for this patient. Providing that supportive care, including fluid management and addressing potential respiratory issues, is going to be important for stabilizing that patient while they're preparing for dialysis or another type of advanced medical care. Gynecologic problems are a frequent cause of acute abdominal pain in women. When assessing a female patient with lower abdominal pains and tenderness, it's going to be important to consider the possibility of issues related to the ovaries, the fallopian tubes, or the uterus. So these organs can be affected by a variety of conditions ranging from routine menstrual cycle processes to more serious reproductive health concerns. For example, pain may be associated with ovulation when an egg is released from the ovary as part of the menstrual cycle. While this is a normal process, some women may experience significant discomfort during ovulation, known as I think it's called Mittelschmerz. So Mittelschmerz, it's a word that I'll try my best to pronounce. So it's spelled Mittelschmerz. Mittelschmerz. So more serious conditions such as ovarian cyst, ectopic pregnancies, or pelvic inflammatory disease, PID, can also present with similar pain patterns, making a thorough assessment very important for these patients. So recognizing the potential gynecologic causes of abdominal pain ensures that the patient receives the appropriate and timely care, whether the condition is routine or requires an urgent intervention. So, when assessing a female patient with acute lower abdominal pain, always consider gynecologic causes, especially if the pain is localized to the pelvic area. So we're going to ask about the patient's menstrual cycle and reproductive history to help narrow down the possible causes. So conditions like ovarian cyst, ectopic pregnancies, and PID can lead to significant complications if it's not addressed quickly. So monitoring vital signs and providing supportive care while arranging for rapid transport is going to be very important for these patients. All right, so speaking of pelvic inflammatory disease, PID, it's a common cause of acute abdominal pain in women. It is an infection of the fallopian tubes and surrounding pelvic tissues, often caused by sexually transmitted infections like chlamydia or gonorrhea. The infection can spread and it causes significant inflammation and pain in the lower abdomen, okay? So patients with PID typically present with acute lower abdominal pain and tenderness there, which may be severe for those patients. So the pain is often accompanied by other systemic symptoms such as a high fever, chills, and general malaise. So in severe cases of PID, it can lead to complications such as scarring of the fallopian tubes, infertility, or abscess formations, making a prompt recognition of this and treatment very important for these patients. So PID can sometimes be mistaken for other causes of acute abdomen, such as appendicitis or ectopic pregnancy. So obtaining a thorough patient history, including sexual history and menstrual patterns, is essential for an accurate diagnosis. So if you have a female patient presenting with lower abdominal pain and fever, we need to consider pelvic inflammatory disease as a potential cause. So assess for signs of infection such as fever and tenderness, and gather a detailed history, particularly focusing on sexual health. So we're going to include prompt transport and treatment, because those are going to be important to prevent long-term complications like infertility and abscess formation. So supportive care should also be included, things like managing pain and monitoring for signs of sepsis or other types of systemic infections. All right, ectopic pregnancy occurs in approximately 1 to 2% of all pregnancies and is a life-threatening condition in which the fertilized egg implants outside the uterus, most commonly in one of the fallopian tubes. Since the fallopian tube is not designed to support the growth of a fetus, it can only sustain the pregnancy for about 6 to 8 weeks before it ruptures. So when an ectopic pregnancy ruptures, it can cause massive internal hemorrhage and acute severe abdominal pain. Usually it's going to be localized to one side of the abdomen. So this condition is a medical emergency at this point, and it can lead to hypovolemic shock due to significant internal blood loss. So symptoms may include dizziness, fainting, shoulder pain, which will be a referred pain, and signs and shocks such as rapid heart rate, low blood pressure, and pale and clammy skin. So immediate recognition and intervention are critical to prevent life-threatening complications from this condition. So, in a female of childbearing age presenting with acute lower abdominal pain, particularly if it's localized to one side and associated with signs of shock, an ectopic pregnancy should strongly be suspected in this case. So be alert for associated symptoms like dizziness, fainting, and that referred shoulder pain we talked about. So with this, immediate transport to an emergency facility is going to be very essential, as this condition requires urgent surgical intervention to control internal bleeding and save that person's life. So it's very serious stuff there. Epididymitis and orchitis are complications of male urinary tract infections, or UTIs, in men. So this can result in inflammation and infection of the male genital tract. Epididymitis involves the inflammation of the epididymis, which is going to be the structure along the posterior border of the testes. While orchitis occurs when one or both testes become infected. So patients with orchitis will present with enlarged and tender testes, leading to significant pain and swelling in the scrotum. So the swelling may extend into the groin on the affected side, and the pain can increase during bowel movements. So in addition to pain and swelling, patients often have systemic signs of infection, including fever, and they may report a foul-smelling urine. Pre-hospital management of epididymitis and orchitis primarily are going to involve providing supportive care, ensuring patient comfort, and monitoring for complications. So, when you're assessing a male patient with scrotal pain, swelling, and signs of infection such as fever or foul-smelling urine, we're going to consider the possibility of epididymitis or orchitis. While these conditions are not immediately life-threatening, they can lead to further complications if they are untreated. So supportive care should focus on pain management and ensuring rapid transport to a healthcare facility for evaluation and treatment, which is absolutely recommended for these patients. Priapism is a painful, persistent erection that can occur without sexual arousal and can last for hours. So this condition requires prompt medical attention, as prolonged priapism can cause permanent tissue damage to the penis if it's not treated. So priapism can result from a variety of causes, including diseases like leukemia and tumors. Also, blunt trauma to the perineal area, spinal cord injuries, or the use of substances such as cocaine or prescription medications, including drugs for erectile dysfunction. So when we're managing a patient with priapism, it's crucial to maintain their privacy and to avoid making assumptions about the cause of it. So this condition can be embarrassing for the patient in itself. So providing compassionate care and support is going to be very important for these patients. So pre-hospital care for priapism is supportive, focusing on the patient's comfort and ensuring rapid transport to the medical facility so they can get further evaluation and treatment for this. So, in a patient presenting with priapism, ensure that their privacy is respected and provide supportive care. So priapism can result from those various causes, right? Including trauma or that medication use. And it should be treated as a medical emergency due to the risk of permanent tissue damage. So transport the patient promptly to a healthcare facility for further evaluation and further intervention for these patients. Testicular masses are going to be a condition that typically does not require pre-hospital treatment unless it's associated with significant pain or discomfort. So these masses can either be painful or they can be painless. So painful testicular masses may cause discomfort localized to a specific point on the scrotum, or it may radiate along the spermatic cord. So while painless masses often go unnoticed until they are found during self-examination or routine medical checkups. So most testicular masses are benign, such as cystic masses or a what's called a varicocele, I think it is. Varicocele. I think that's close to what it is. So these are going to be a painless mass of dilated veins located behind the testicle. However, testicular cancer, which often presents as a painless solid lump on a testicle, should always be considered in the differential diagnosis. So early detection of testicular cancer is going to be crucial for successful treatment outcomes for these patients. So with these patients, when you're encountering a patient with a testicular mass, especially if it's painful, we're going to assess for any radiating discomfort along the spermatic cord or localized pain in the scrotum. While many testicular masses are benign, always we're going to consider the possibility of testicular cancer, particularly if the mass is painless. Although pre-hospital treatment is not typically going to be necessary, providing reassurance and advising follow-up with a healthcare provider is going to be very important for this patient. All right, so we talked about the testicular masses being that condition that typically doesn't require pre-hospital treatment unless it's associated with that significant pain or discomfort. So those masses, they can be painful or painless, because the painful testicular masses may cause discomfort localized to a specific point on the scrotum, and then it radiates along the spermatic cord, right? While painless masses often go unnoticed until they're found during self-examination or those checkups like we talked about. So we know that they're benign, however, we got to consider that testicular cancer piece, which often presents as a painless lump on the testicle. We got to consider that. So don't forget about that. So it talks about here this testicular torsion. So we know that it talks about that testicular torsion being that twisting on the spermatic cord. All right, so this is going to be, the testicular torsion is going to present with a onset of scrotal pain and swelling. It's going to be severe pain for these patients. So this is a medical emergency because the twisting vessels, it reduces this blood flow, which is going to be needed in that area. So we want to make sure what happens to anything whenever there's a blockage of blood flow to the area, it starts to get ischemic, right? So to keep it from getting ischemic, it needs to get oxygen and nutrients to the other side of that blockage, and that torsion is what's creating the blockage. So it can occur with or without blunt trauma or testicular lump or blood in the system where there is. So we want to make sure that when we're evaluating for that, we're asking the patient, how long ago did this start? Especially when we're talking about on a scale of 1 to 10, 10 being the worst pain you ever felt. What were you doing when this started? So on and so forth, so that we can get a full evaluation, take your vital signs, and then head to the hospital so this can get dealt with immediately. All right. The aorta is the largest artery in the body. It lies just behind the peritoneum along the spinal column. In older individuals, the wall of the aorta can weaken over time, and this leads to the development of an aneurysm possibly. So an aneurysm is a swelling or an enlargement of a part of an artery due to the weakening of the arterial wall. So aortic aneurysms often develop slowly and are typically asymptomatic unless they begin to dissect or rupture. So if an aortic aneurysm ruptures, it can result in a massive internal hemorrhage, very massive. So patients may present with signs of acute abdominal pain, usually accompanied by severe back pain. All right, so I've heard it called burning or ripping as far as back pain. So this condition is life-threatening. It's absolutely life-threatening. Signs of acute peritoneal irritation may also be present due to the internal bleeding in these patients. So ruptured aneurysms require immediate recognition and intervention to prevent death from massive blood loss. And since it's in the aorta, it can happen very quickly. So when a patient presents with severe abdominal or back pain, particularly if they're elderly or have a known cardiovascular disease, an aortic aneurysm should be considered for this. So the rapid onset of hypotension, tachycardia, and signs of shock strongly suggest a ruptured aneurysm. So immediate transport and advanced care are going to be essential for survival, as rapid surgical intervention is the only treatment for a ruptured aneurysm. All right, a hernia occurs when an organ or tissues protrude through a hole or an opening into a body cavity where it does not belong. So hernias can develop due to various causes, including congenital defects such as those around the umbilicus. Also, failure of a surgical wound to heal properly can cause issues, or natural weaknesses in certain areas of the body like the groin. So while hernias often produce a noticeable mass or lump, this is not always the case, particularly in individuals with extreme obesity. So where detecting the mass, it can be quite challenging in itself. So hernias are categorized into two types. You have reducible hernias and you have incarcerated hernias. So reducible hernias, they pose little risk as they can be pushed back into the body cavity. However, if the mass cannot be pushed back, it's referred to as an incarcerated hernia, which can lead to complications if it's left untreated. Incarcerated hernias can potentially become strangulated, all right, and this cuts off blood flow to the trapped tissue, which can cause tissue death, right? And it leads to serious complications requiring immediate surgical intervention in this case. So when evaluating a patient with a known or suspected hernia, determining whether the hernia is reducible or incarcerated is going to be key. If the hernia cannot be reduced and is causing significant pain, we're going to prompt transport, or we're going to see that prompt transport is taken for these patients. Incarcerated hernias can become life-threatening if they progress into this strangulation phase. So careful monitoring for shock and also for severe pain is going to help guide our urgency in this intervention with these patients. All right, we talked about the here's a diagram here. So we talked about the incarcerated hernias where the protruding organ and tissue cannot be pushed back into the body cavity, right? And how much of a risk it does pose to these patients. So if the surrounding tissue compress the hernia, it can compromise that blood supply, leading to this condition known as that strangulation. So at this point, it becomes a strangulated hernia, and it's a serious medical issue because of due to lack of oxygen on the other side, right, to those tissues. So immediate surgery is going to have to happen. So hernias, they can occur in several common locations within the abdomen. And you can see here in the photo. So you have epigastric, which is above the belly button in the upper abdomen. You have umbilical around the belly button. You have inguinal, which is going to be in the groin area, one of the most common locations of hernias. And then you have femoral, which is near the upper thigh, just below the groin area. So these types of hernias can occur due to weaknesses in the abdominal wall. It can be congenital defects or other factors such as surgical wounds or natural weaknesses. All right, so we talked about in the past slides additional signs or about signs and symptoms of the strangulated hernias due to the fact that they're incarcerated. So recognizing that, you can see a little bit here for the serious hernia signs and symptoms. So some additional signs are going to be pain at the hernia site, which may become increasingly severe, tenderness upon palpation of the hernia, skin discoloration over the hernia, particularly red or blue patches, because this can indicate compromised blood flow or strangulation automatically. So those symptoms suggest that the hernia may be strangulated, and then meaning that the blood supply is trapped, has the trapped tissue is going to be compromised. So this will lead to tissue death, which is not good for that patient, right? Seeing size up is the first step in assessing any patient, including those patients with acute abdominal pain. Ensuring the safety of the scene is paramount, as acute abdomen can sometimes be the result of trauma. So including these traumas can be like your blunt or penetrating injuries. So when approaching the scene, remain vigilant for clues that might help you determine the nature of illness, such as environmental hazards or signs of violence. So we're going to take standard precautions, including wearing gloves and eye protection in certain situations, such as when dealing with bodily fluids or the potential for contamination. We're going to consider donning a gown and shoe covers to protect yourself further. So also determine the number of patients at the scene. If multiple individuals are complaining of gastrointestinal symptoms such as abdominal pain, nausea, vomiting, or diarrhea, this could suggest on the higher end a release of a biological or chemical agent. So many biologic or chemical agents can induce similar GI symptoms. So you must be alert for the possibility of a mass casualty situation caused by an environmental factor. Patients with renal or genital problems often exhibit many of the same symptoms as those with gastrointestinal issues, including nausea, vomiting, constipation, diarrhea, flank pain, and generalized abdominal discomfort. So given the overlap in symptoms, careful assessment is required to identify the underlying cause. So the location where the patient is found can also provide important clues about what happened. So for example, a patient exhibiting extremes of activity, such as constantly changing positions in an attempt to find comfort, or sitting very still with their knees drawn to their chest, it may suggest severe abdominal or renal pain. So in some cases, patients are comfortable only when lying in one specific position. So this positioning, it can offer insights into the nature of the pain. So odor is also an important aspect of your general impression. So few EMS calls involve truly noxious odors, but gastrointestinal or genitourinary issues can sometimes present with a strong, unpleasant smell. And this can indicate infection or other complications also. So it's important to remember that you are not expected to determine the exact cause of acute abdomen. Instead, your priority is recognizing potential causes and providing the appropriate supportive care. So though gastrointestinal problems may affect breathing directly, severe complications I said that wrong. So though gastrointestinal problems rarely affect breathing directly, severe complications actually can. So you're going to ensure that the patient's airway is clear and patent, and especially if aspiration has occurred, you're going to have to clear it and make it patent. So patients with shallow or inadequate respirations may be experiencing intensified pain when attempting to take deep breaths. So the assessment of the circulatory system is going to be very important when dealing with GI issues, as it provides insight into how the condition is affecting the body. So key indicators such as a pulse rate, pulse quality, and skin condition may reveal early signs of shock, which may result from blood loss, that hypovolemia, right? Or a severe infection such as like sepsis. So, always check the pulse in both arms during your assessment. A difference in pulse strength between the arms can indicate an aortic dissection, like we talked about in a past chapter, which is going to be a life-threatening condition requiring immediate attention, right? So we're going to expose the patient fully to assess the major bleeding. So trauma naked, right? So which can sometimes be hidden beneath clothing. So we need to make sure, get them trauma naked, get them ready, do our due diligence. So many GI conditions involve both pain and hemorrhage, which shock being the most common complication for this. So if you detect signs of shock such as tachycardia, weak pulse, pale and cool skin, or altered mental status, your immediate interventions should always include administering high flow oxygen, keeping the patient warm, and positioning them according to local protocols. Usually it's going to be supine or with their legs elevated. Also, they need those IV fluids then, right? So, prompt recognition of life-threatening symptoms and rapid transport are going to be very important. Once the identifying signs of shock, once you identify those signs of shock, you want to focus on stabilizing that patient, preparing for rapid transport so that they receive definitive care as quickly as possible. All right, assessing orthostatic vital signs, it can help you determine the extent of blood or fluid loss that a patient has experienced. So we're going to begin by having the patient assume a position of comfort, usually sitting or lying down, and then we're going to take an accurate baseline blood pressure and heart rate. So after a minute or two, you're going to have the patient carefully change positions from lying to sitting. All right? And we're going to repeat the measurements. So be cautious to prevent the patient from losing consciousness during this maneuver. So in a healthy patient, vital signs will show little to no change in between positions. However, in a patient who has experienced significant fluid or blood loss, you may observe a 10 beat increase in heart rate or a 10 millimeter of mercury drop in blood pressure. All right, so this condition is known as orthostatic hypotension. So this indicates a loss of volume within the vascular space, often due to bleeding or dehydration. So when examining a patient with a gastrointestinal issue or GI issue for gross bleeding, it's going to be important to accurately assess the volume of blood loss. So it is common for people to overestimate blood loss due to emotional reactions or the difficulty in gauging diluted blood, such as in a toilet. So we're going to practice estimating blood volume by pouring measured amounts of water into different surfaces to become familiar of how blood volume looks in various contexts. So that's how we get practicing. That's how we did it with our trauma training. Is we used actual we used the fake blood when we did it, and then we would put it on different surfaces. When in all actuality, the best way to tell is by putting your hands on the patient and viewing your patient. So pale, cool, clammy skin, heart rate, all their breathing issues, blood pressure. That's how you're really going to determine shock. So when making a transport decision for a patient with a GI or abdominal emergency, it is important to integrate information gathered from the primary assessment. Certain patients should be prioritized for rapid transport, particularly those with life-threatening conditions or signs of significant illness, right? So patients who should be packaged quickly and transporting without delay are going to include patients with airway, breathing, and circulation problems, such as compromised pulses or poor perfusion, patients with suspected internal bleeding, which can quickly lead to shock and organ failure. Also, patients with a poor general impression. All right, so especially vulnerable populations like your pediatric or geriatric patients. Also, patients showing other critical signs such as pale, cool, diaphoretic skin, tachycardia, hypotension, altered level of consciousness. In those cases, immediate transport to a medical facility is going to be very important to ensure timely intervention and care. So during transport, we're going to ensure the ride is as smooth and as gentle as possible. We're going to make sure that we're driving smoothly and then we're driving steadily, because that's going to help minimize discomfort for the patient, and it prevents worsening of symptoms, especially in those experiencing severe pain and shock. So pain is often a very important finding, like you see here. So pain can indicate different types of things. It can indicate if there's a massive hemorrhage, any trauma, if there's infections, internal bleeding, anything like that, or internal hemorrhaging, if there's obstruction that's somewhere down the line for this patient. Pain is a very important indicator for patients. All right, so our main way to get an assessment for pain is OPQRST, onset, provocation, quality, radiation, severity, and time. So we want to make sure that we use that as an assessment tool to make a determination on what type of pain and how bad the pain is, so we can make other transport decisions for our patient and get them to where we need to get them to go. All right, also, when we're making our assessments, when assessing that patient with a urologic or a GI problem, we're taking a detailed patient history and performing a thorough physical examination that's often going to provide the essential information needed to manage this situation, right? So the sample history is particularly going to be helpful for eliciting this relevant current and past medical information. So some things that it includes, like your symptoms, allergies, your medications, and events leading up to the injury or illness for these patients. So you may need to discuss these topics that are not typically described in everyday language. So it's crucial to establish clear communication with that patient. So make sure both you and the patient have common understanding of the symptoms and their descriptions. So some key questions to ask include, have you experienced nausea or vomiting? Have there been any changes in bowel habits? Are there any changes in urination, such as like when we're talking about frequency, pain, or color? Have you noticed any weight loss? Did you experience frequent belching or flatulence? Can you describe the pain? So when we're using like OPQRST for a pain assessment. So are there any other symptoms that you've noticed recently that may contribute to your discomfort? Do you have any concurrent chest pain? So for female patients, it's important to ask about their last menstrual period, as this may provide a crucial context for their symptoms. So additionally, ask all patients about their last oral intake, but do not allow the patients to eat or drink anything. So finally, inquire about the events leading up to the illness or injury, and this can help determine the condition and if the medical is trauma or if it's trauma related. When assessing a patient with potential GI or urologic issues also, it's going to be essential to getting those specific focused questions. We talked about that OPQRST, right? So when did this pain start? What makes the pain better or worse? Can you describe the pain? Is it sharp? So when you're asking them to describe the pain, let them describe to you. But some things that they may use is sharp, dull, burning. We don't want to ask them, is it sharp pain? Is it dull pain? Because we don't want to lead them. We want them to answer that question honestly. Also, does the pain move or spread anywhere else? On a scale of 1 to 10, how severe is their pain? How long has the pain lasted, and has it changed over time? All right, so for female patients, again, we want to make sure that we ask about their last menstrual cycle, as menstrual-related issues can sometimes cause or contribute to abdominal pain. So this information can help determine whether a gynecologic cause is likely for your female patients. So in all patients, we want to make sure that we ask about their last oral intake, but again, we're going to make sure we do not give them anything by mouth, as this could complicate later medical interventions or surgery. So additionally, always ask about the events leading up to the illness or injury, again, because we need to find out or get a fine point if this is a medical emergency or is it trauma related. All right, so the secondary assessment focuses on a physical examination of the abdomen. Usually the information gathered during a history taking, during your history taking is going to guide your evaluation. So a normal abdomen should be soft and non-tender to the touch. In cases of an acute abdomen, pain and tenderness are the most common symptoms. So pain can be sharply localized to a specific area or diffuse throughout the entire abdomen, and its severity can actually vary. So localized pain may offer clues as to which organ area that's affected, okay? In some cases, the muscles of the abdominal wall may become rigid as a protective mechanism to prevent further irritation. So this condition is known as guarding, okay? So this board-like muscle spasm often indicates serious conditions like a perforated peptic ulcer or pancreatitis. So a patient with peritonitis typically experiences continuous abdominal pain even while lying still. They may also display difficulty breathing, taking rapid shallow breaths to avoid further discomfort. So also something else, palpation of the abdomen will usually reveal tenderness, and the severity of tenderness is often directly related to the level of peritoneal inflammation. So an abdominal assessment requires a systematic and gentle approach for this. So we're going to start by explaining the procedure to the patient to reduce anxiety and encourage cooperation. We're going to position the patient in a supine position with their legs drawn up and flexed at the knees. So in cases of trauma, we're going to keep the patient supine and stabilized. We're going to pay attention to the patient's behavior, whether they are restless or quiet, and we're going to assess if the movement increases their pain. So we're going to begin the assessment by exposing the abdomen and conducting a visual inspection. We're going to ask the patient where the pain is at. We're going to ask the patient where the pain is at and where is it most intense. And then we're going to start palpating in a clockwise direction, beginning with the quadrant next to the pain area, like away from it, and ending with the most painful quadrant. So we want to make sure that we stay away from it until we get to that area where the pain is at. So this is going to help prevent the patient from guarding against further examination. So we're going to palpate gently, especially if there's a pulsating mass, so which should not be touched, by the way. We're going to assess each quadrant to determine whether the abdomen is tensed or if it's guarded or is it soft. So we're going to observe whether the pain is localized or is it widespread, and we're going to carefully note the patient's responses without asking leading questions like, does it hurt here? All right, we're going to go off their responses. We're not just going to constantly ask, does it hurt here? Does it hurt here? All right, so rebound tenderness is a sign of peritonitis, and it should be assessed with caution due to the pain that it may cause. So finally, we're going to determine whether the patient can relax the abdominal wall on command. So guarding or rigidity may indicate peritoneal irritation, or it can show that there's a more serious condition involved. So when we're assessing a patient with abdominal or urologic issues, respiratory and circulatory signs provide important clues to their condition. A high respiratory rate with a normal pulse rate and blood pressure may indicate improper ventilation, and this could signal potential respiratory distress, or it can indicate oxygen exchange, okay, or inadequate oxygen exchange, more so. So conversely, a high respiratory rate coupled with a high pulse rate and accompanied by signs of shock such as pallor and diaphoresis, sweating, right? Pallor, that pale skin, and diaphoresis being that sweaty condition, it could suggest septic or hypovolemic shock. So these findings highlight the importance of closely monitoring the patient's vital signs to detect the early onset of shock or other life-threatening conditions. For accurate assessments, we're going to use tools like pulse oximetry and non-invasive blood pressure devices. However, it is essential to obtain the patient's first blood pressure reading normally needs to be a manual blood pressure. And we're going to use an actual blood pressure cuff and stethoscope for this. So manual blood pressure should be the first blood pressure that you use. All right, so this is going to ensure a precise baseline, and it helps identify any potential issues with circulation or blood pressure regulation. All right, reassessment. So reassessment is going to be a crucial part of managing patients with acute abdominal or urologic emergencies, as their condition can deteriorate rapidly. So frequent reassessment helps to track changes and ensure timely interventions for these patients. So we're going to start by comparing the patient's current vital signs with their baseline measurements. If there are any changes during the transport, such as worsening pain or new symptoms, immediately we're going to manage the problem and document any modifications to treatment. So during reassessment, we're going to ask important questions such as, has the patient's level of consciousness changed? Are they becoming more anxious? Has their skin appearance altered? Is their pain improving or is it worsening? Has there been a change in bleeding? Additionally, we're going to assess whether the current treatments are improving the patient's condition or if any new problems have developed. So for patients with gastrointestinal bleeding, we're going to closely monitor for signs of shock. Before administering additional fluids, we're going to listen to lung sounds to check for signs of pulmonary edema. If the patient prefers lying on their side for comfort, try to accommodate this while maintaining their airway also. So if the patient's condition becomes unstable, we're going to call for a paramedic backup or consider air transport if necessary for these patients. So patients with urologic emergencies, especially those showing signs of renal failure, need to be continuously monitored for electrolyte imbalances. This can cause rapid changes in organ function if this becomes an issue. So we need to do serial vital signs for these patients. Ideally, we want to do this every 5 minutes, and it should be recorded so we can observe what trends, that trending process that I'm big on. So we're going to keep in mind that patients with urologic issues should not receive anything by mouth. I've said that several times. Don't do it by mouth. So an acute abdomen is going to signal a serious medical or surgical emergency requiring an immediate attention. Your primary role is to provide prompt and gentle transport without delaying care. So time is critical, and although it's not your responsibility to diagnose the exact cause of an acute abdomen, it is essential to stabilize and monitor the patient as quickly as possible before transport. So first and foremost, we're going to ensure that the patient's airway is clear and maintained. So this is going to be a vital step in all patients, right? So particularly those that may be vomiting or experiencing severe distress. So continuous monitoring of the airway is going to help prevent further complications such as aspiration, which can lead to additional respiratory issues. We're going to ensure suction is readily available to manage any secretions or vomiting during transport. So when caring for a patient with an acute abdomen, anticipate complications such as vomiting. We're going to place the patient in a recovery position or a position of comfort to protect the airway and reduce the risk of aspiration. We're always going to be prepared for vomiting, and we're going to have suction ready and available if we're going to have those type of issues, especially nausea. Get you a emesis bag, get your suction ready, make sure it's ready to go. We're going to administer 100% supplemental oxygen to maintain that adequate oxygenation, and we're going to be ready to assist with ventilations if the patient has a reduced tidal volume or signs of respiratory distress, right? So it's going to be crucial that nothing is given by mouth. Nothing is given by mouth. Nothing is given by mouth. All right, so because this could worsen the condition and it can interfere with future surgical procedures also. So as a part of your documentation, we're going to gather and record all the pertinent information using OPQRST for pain. And this is going to assess that patient's pain and symptoms. And then we're going to monitor for development of hypovolemic shock. So paying close attention to changes in blood pressure and other signs such as tachycardia, pallor, and diaphoresis. So if shock becomes evident, we're going to treat the patient accordingly, including positioning the patient appropriately. We're going to provide oxygen, keep them warm. If it's indicated, we're going to establish IV access also. So for patients showing signs of hypovolemia, we're going to administer a 20 mils per kg bolus of isotonic crystalloid solution for an adult. 20 mils per kg. That's going to be a bolus of isotonic crystalloid solution. If the patient does not show signs of hypovolemia, we're going to maintain fluids at a keep vein open rate, otherwise known as KVO. So in cases of urinary tract infections or kidney stones, if kidney function is present, a fluid bolus can help support renal function in this aspect. When caring for a patient with an acute abdomen, we're going to anticipate complications such as vomiting, right? So we're going to make sure that that patient's in the recovery position of comfort. We're going to have that suction readily available. All right, we're going to make sure that we have that 100% oxygen out there, and then we're going to make sure that nothing is given how? By mouth. Also, if needed, we're going to make sure that if they're under respiratory distress or reduced tidal volume, that we can provide those respirations mechanically for that patient. All right, we're also, as part of our documentation, OPQRST, we're going to monitor for hypovolemic shock, pay close attention to that. We're looking for that tachycardia, pallor, diaphoresis if shock becomes evident. We're going to make sure that IV access is started with how much? How much fluids in a bolus of isotonic crystalloid solution? 20 mils per kg. 20 milliliters per kg. All right, for our adult patients. Awesome. All right, pelvic inflammatory disease. We talked about this earlier. We're going to review it. So it's a serious infection that can cause intense pain and tenderness in the lower abdomen. So often accompanied by a high fever. If you suspect PID, we're going to have immediate transport to the emergency department. It's going to be very essential for this. So the infection can lead to severe complications, including infertility and sepsis if it's left untreated. So we're looking for this in our female patients, right? So when you encounter a combination of acute abdominal pain and signs of hypovolemic shock, particularly in our females of childbearing age, we're going to consider that it's possibility that it could be an ectopic pregnancy. So it's a life-threatening condition that can present with acute abdominal distress and hypotension, indicating significant internal bleeding. So any female with those symptoms should be treated as a high priority, and we want to make sure that we give rapid transport and definitive care that it's going to be crucial. Get that IV line. Get that IV line going, ladies and gents. All right, pneumonia. So pneumonia, though it's primarily a respiratory condition, can sometimes cause ileus. So that's going to be ileus is this disruption of normal bowel function, and it can cause abdominal pain. So the issue originates in the adjacent thoracic cavity, but the inflammatory response can extend and affect the abdomen, leading to discomfort or pain that mimics gastrointestinal issues. So when managing this patient with abdominal pain due to pneumonia, the approach remains the same as for any other patient with acute abdominal pain. We're going to assess, treat, and transport these patients very promptly. So monitor the patient's respiratory status closely, as pneumonia may also compromise breathing, and it can. We want to make sure to ensure that they receive appropriate in-route care to the hospital. All right. So when a patient presents with acute abdominal signs and symptoms accompanied by shock, it may indicate that life-threatening conditions such as an aneurysm also. So this situation is going to require immediate transport to a medical facility for advanced intervention. So during your assessment, we're going to avoid any vigorous or unnecessary palpation of the abdomen, as this could worsen the condition, especially if an aneurysm is suspected. So we're going to focus on stabilizing the patient and minimizing movement to prevent rupture. So if the patient is hypotensive and showing signs of shock, we're going to administer fluids cautiously, giving enough to support blood pressure only. So titrate for effect, right? So what I'm looking for in those patients is a systolic, the top number, above 90, all right, or at 90, all right, not much further above it. All right, so overaggressive fluid resuscitation in those patients could increase the risk of bleeding, so we're going to maintain careful monitoring. So systolic pressure at 90, that's probably good enough to get them there, right? So for patients with signs and symptoms of a hernia, such as abdominal pain or a visible bulge, prompt transport is going to be emergency department. Get them there. So even if the hernia appears reducible, timely evaluation by a physician is going to be critical to prevent complications like incarceration or strangulation of this. So in patients with acute kidney injury or AKI or chronic kidney disease, CKD, the condition can quickly escalate into a life-threatening emergency. So support of the airway, breathing, and circulation is going to be the highest priority always. We're always going to be alert for signs of hypotension or pulmonary edema as well, as those complications are common due to fluid and electrolyte imbalances. So patients with AKI or CKD may require medications to regulate acidosis and electrolyte imbalances, as well as they may need fluids to address volume issues as well. And that's all you, right? So, however, it's going to be important to prioritize the emergency transport and supportive care over aggressive management in the pre-hospital setting. So we need to allow hospital staff to manage those conditions in a controlled environment. So renal dialysis is the only definitive treatment for patients with chronic end-stage renal disease, ESRD, right? So this process filters the patient's blood to remove toxins, and it helps to normalize the blood chemistry. It also reduces excess fluid. So dialysis can often lead to calls for pre-hospital care as complications arise from the treatment itself. There are two main types of dialysis. You got your peritoneal dialysis and your hemodialysis. In peritoneal dialysis, a large amount of specifically formulated dialysis fluid is infused into the abdominal cavity, where it remains for about 1 to 2 hours before being drained. So this method can be performed at home with proper training, but it carries a high risk of peritonitis. So that's going to be that serious infection of the abdominal cavity, right? Hemodialysis is more common and involves circulating the patient's blood through a machine that mimics kidney function. So most patients undergoing long-term hemodialysis have a surgically created shunt. All right, and it's usually in the forearm or the upper arm, which connects a vein and an artery. The dialysis machine is connected to this shunt. Some patients may have a hemocyte, all right, which is going to be a small button-shaped device with a rubber septum for a needle access, right? Or an arteriovenous fistula, an AV fistula. So this is going to be an internal shunt that's used for IV access in emergencies. So dialysis patients typically undergo treatment every 2 to 3 days for 3 to 5 hours. However, they are vulnerable to complications such as machine malfunction, accidental disconnection, or rapid shifts in fluid and electrolytes. So while dialysis is a critical treatment for patients with end-stage renal disease, it can result in various adverse effects and complications that require close monitoring. So these are going to include things like hypotension, which is common due to fluid shifts during treatment, muscle cramps, often resulting from electrolyte imbalances, most of the time how that happens. You got your nausea and vomiting, typically due to fluid and electrolyte disturbances there. And then you have hemorrhage at the access site, especially in patients who use anticoagulants. So you can also have this infection at the site. This can be due to an increased risk of introducing bacteria to the bloodstream itself, and this happens repeatedly, right? You can also have the altered mentation or loss of consciousness, and this is going to signal a more severe complication, possibly related to electrolyte imbalances or hypotension. You can also get what's called an air embolism. All right, we've talked about this before as well. So it's a rare, but it's a life-threatening complication that it can occur during hemodialysis. So air embolism. So it's air and embolus, right? Moving. So the air moves and it gets to a spot where it creates a blockage, and that creates big issues there. Also, you can have electrolyte imbalances, particularly with potassium, and it can cause cardiac dysrhythmias for these patients. Also, something else that can happen is myocardial ischemia, right? And this can occur from fluid shifts or that electrolyte disturbances that stress the heart. So all of those complications have serious consequences if they aren't recognized and treated very promptly. So we want to make sure we study up and we know when we see these. All right, and this is pretty much from what we looked at before. Sudden drop in blood pressure, so immediately after, so it can be different issues. We talked about the electrolyte imbalances could cause that. So when responding to a call involving a patient receiving dialysis, we always start with the ABCDEs. All right, that's going to be that airway, breathing, circulation, disability, and exposure. All right, so we're going to administer high-flow oxygen. We're going to address any bleeding from the access site immediately. If the patient is experiencing pulmonary edema, we're going to try to position them sitting up to ease the breathing. For patients in shock, we're going to keep them supine, and we're going to transport promptly, right? Very quickly. If you find a shunt that's leaking during dialysis, we're going to check the connection and see if it can be tightened. If it's become disconnected from the vein, we're going to clamp the cannula and we're going to disconnect the patient from the machine. So in cases where the patient has intentionally opened the cannula, like in the case of a suicide attempt, for example, we're going to immediately clamp it off and we're going to apply direct pressure to control the bleeding. So some dialysis patients also have urinary catheters, which can be a source of infection as well. So patients may report a fever or malaise or other symptoms for that. So we do not want to remove the catheter. Instead, we want to treat the symptoms and transport the patient for further evaluation. So during transport, unless there's a life-threatening event, we want to try to ensure that the patient is delivered to a hospital with dialysis capabilities, as this will facilitate proper care and management of their condition. All right, so disequilibrium syndrome. All right, so this is a condition that can occur during or after dialysis. So this can result from a rapid reduction in urea concentration in the blood. So while the concentration of solutes in the cerebral spinal fluid remains elevated, okay? So that's how this is going to happen. So this imbalance causes water to shift from the bloodstream into the CSF, all right, that cerebral spinal fluid. And this leads to a mild increase in intracranial pressure. So patients experiencing disequilibrium syndrome may present with symptoms such as nausea, vomiting, headache, and confusion. So these symptoms are going to be generally temporary and will improve as the fluid levels start to balance out between the blood and the CSF. They're going to, what we call, gradually re-equilibrate, all right? Or equilibrate, something like that. They're going to become equal. It's going to get homeostasis again. So, and this can take over the course of a few hours. So while disequilibrium syndrome typically resolves on its own, recognizing is going to be very important for proper care and reassurance to the patient. So just giving that patient information. All right, that air embolism we talked about, that serious complication that can occur if the fittings or the connections of the dialysis system are loose. And this allows air to enter the patient's bloodstream. So this condition is life-threatening and it requires immediate intervention. So symptoms of air embolism include sudden dyspnea, that difficulty breathing, hypotension, and cyanosis, that blue discoloration of the skin, right? If you suspect an air embolism, we're going to promptly disconnect the patient from the dialysis machine and we're going to begin emergency management of that patient. So immediate recognition and treatment are going to be crucial to prevent further complications and ensure patient survival. So that quick disconnection and then getting them to the hospital as quickly as possible. If anything pops up, they start to go out or anything like that, we need to act accordingly, whether it be for CPR or anything that's needed of them, mechanical ventilation, whatever we need to do to help that out. All right, so at this part, we're going to skip through this because this would generally take place in the live class. So, before we wrap it up, we don't forget to complete the attendance form located in the student dashboard if you attended the class. Like we talked about before, your feedback is incredibly important to all of us, and we want to make sure that we're working well with you and that we're doing what we need to do to further your education. So if you feel like we deserve anything less than 5 stars, let us know why so we can make adjustments so we can aim for 5 stars in the next lecture, right? So also, quick reminder, upcoming quizzes, they are due Saturday at 11:59 p.m. Central Standard Time. This Saturday at 11:59 for our live classes at 11:59 p.m. Central Standard Time. So they're going to cover neurologic emergencies and Chapter 20, gastrointestinal and urologic emergencies. So by the way, Chapter 21, immunologic emergencies, will be the topic of our next lecture on Monday. So study up and be ready to ask questions as well as to answer any questions that I might throw out there. All right, so if you have any questions about tonight's lecture or anything, feel free to let me know. Send out email if you need to. If you're not, then if you're ready to go, head on out. I really appreciate it. So remember, be safe, be professional, and be a patient advocate. We'll see you next class.